So the title is Causes of Admission and Outcomes in People Living with HIV at CHVK. So we need to congratulate him. He's young, he's fresh, and he's interested in research, and he's going to present to us, and feel confident. And I have seen this presentation is very relevant for science to improve our practice in Rwanda. Thank you. Welcome.
Thank you very much. As the moderator said, my name is Jean-Claude Mungura, and I graduated in University of Rwanda last year in 2019. And before ending our medical school, we did a research on causes of admission and outcome in people living with HIV at CHVK. And I'm going to share with you in 10 minutes what the findings we got from our research. And before starting, I want to thank you for accepting me to participate in this conference. And many of you, they are my mentors, and it's a great motivation for me to present before you this research. My research, I'll be telling you the situation of HIV worldwide, and specifically, I'll talk a little bit about the current situation of HIV in Rwanda, and after I will give you the findings of the research we did last year, and after I'll give you some recommendation to CHVK and also to the Ministry of Health. Without delaying, as you know, HIV is one of the major global health problem worldwide, and this is shown by the increase in number of infected people. And HIV-related disease, mainly opportunistic infection, are the leading causes of morbidity and mortality in HIV patients in middle and low-income countries, including Rwanda. And it was found that due to the gap that are in HIV services, 770,000 of people died from HIV-related causes, or what we call opportunistic diseases. And at the end of 2018, there was estimated of 79% of people living with HIV knew their status, and 62% receiving antiretroviral therapy, and 53 had achieved suppression of HIV virus with no risk of infecting others. And as we know, here in Rwanda, we've achieved the goal of triple 90. Yeah, 90% of Rwandans knew their HIV status, and 90% they had access on RVs, and also 90% of infected people, they are decreasing their viral load. In Rwanda also, since 2005, we are still at the 3% of infected people, and among that, the people aged between 15 and 49, and we have the percent of the infected one, they are women, and 2% they are men. And the prevalence is higher in urban areas, which is now 6%, and in rural areas, it's between 2 and 3%. Based on the study we did last year, we found that the cause of admission, specifically at CHUK, we found that there is the opportunistic disease and non-opportunistic disease. And the study were done on 932 peoples, and 507 were male and 425 were female. And it was a retrospective study, and we analyzed by receiving information from files in internal medicine, and we get other information from archive at CHUK. And as you know, HIV remains a significant health problem in Rwanda, and progressively we are shifting from opportunistic diseases to non-opportunistic HIV diseases. And as the recommendation, we are recommending the Ministry of Health to improve patient screening, to educate patients on need of antiretroviral therapy regimen and its good adherence. And we are recommending also to put in place system that allows an effective cross follow-up of HIV patients that are on treatment, and to give psychological support and to avoid stigma. And for the recommendation for CHUK, we recommend that we have to record patient file appropriately and to get a CD4 and viral load for checking for antiretroviral therapy adherence, and to ensure good medical record keeping, and also to keep doing prospective research to know the current situation of HIV in Rwanda. Thank you very much for your attention.
Thank you, Doctor. We have another set of maybe questions if we'll be having time behind. Thank you very much. So as we are seeing, HIV is still a problem, a public health problem in Rwanda. As we are seeing, people are dying from TB, cryptococcal, all those. This means that people are not suppressing. So we need just to review again our targets, and just people will be linked to care and close follow-up to decrease loss of follow-up, all those. So we'll be having a set of questions. Just write down your questions. So we're going to continue with our second presentation. So it's Dr. Fred Mugabo. He's around. He's going to present on behalf of Dr. Ruhangaza, who is a pathologist at Butaro District. So Dr. Fred Mugabo is a consultant in internal medicine. He's working as Ruhangaza in the Butaro Hospital.
It's my pleasure to present this on behalf of Dr. Deo, who, as they said, is a consultant pathologist at Butaro Hospital. And among the many biopsy examinations he does, some of them are negative for malignancy, and so he decided to share with us this presentation. So as you can see, it's a long-standing unrecognized fungal infections and the contribution of histopathology in the diagnosis. And it's a short presentation using 3 real-life patients. As a quick introduction, cutaneous fungal infections are often unrecognized, and patients cannot seek, sometimes don't seek medical care, and they can even go to traditional healers. And even when they go to medical facilities, they can be treated with the antibiotics, topical treatment, and if it is not appropriate, the lesions can get larger and larger and can take a long time. So we have an example of a 30-year-old woman who had HIV for a long time and was on treatment and reported good adherence to treatment. The CD4 count was unknown, and she reported a 4 to 5 year history of generalized skin nodules that were growing bigger and bigger and were ulcerated. When she presented, the full blood count was not reported. She was reported to have discrete hepatosplenomegaly. The mucosa in the nose, throat, and the mouth was normal, and she had no chest X-ray. This is how she looked in her face and on the extremities. So as a doctor, you can wonder what would be the diagnosis. You can think of many things, but yeah, okay, thank you. So seeing this patient, a biopsy of these regions was done, and from the histopathologist point of view, the dermis looked normal, but I mean the epidermis, but the dermis looked invaded, and on further magnification, these circles in red were found to be histoplasmosis, and you don't see it very well, but there are yeasts in the cells, and they are pushing on the side of the nucleus, and that is how, on further staining, this was confirmed to be disseminated cutaneous histoplasmosis. And this patient, after diagnosis, was sent to the district hospital for antifungal treatment. So a short note on disseminated cutaneous histoplasmosis. It's caused by a fungus, Histoplasma capsulatum, which can be found everywhere in the environment and can cause no problem in immunocompetent individuals, but can disseminate in immunocompromised ones. So it's inhaled into the lungs, and as I said, causes no disease in normal people, but can progress in immunocompetent, immunosufficient patients. So it's one of the opportunistic infections which occurs when the CD4 count is low, below 150. And as I said, the risk factors for progression and dissemination are HIV, AIDS, and immunosuppression in general, immunosuppressive medications for patients, for example, post-transplant. And this is a slide taken from up to date. Almost all patients present at some point in time with fever. They can present with the lung disease, weight loss, as you can see the percentages, and a smaller percentage can present with meningitis. So the treatment is, these are aggressive fungal infections, and you can start with amphotericin, as you know, and then consolidate with the recommended one is itraconazole, and the duration of treatment is much longer. You can go up to 12 months. So another example of a patient that was diagnosed was a 25-year-old woman, now HIV negative, and she had these scalp lesions for almost 6 years, and was operated 2 times, and when she came back for the 3rd time, the surgeon was now cautious and sent a biopsy to pathology lab. This is how it looked, and this was the sample the pathology received, and this is how it looked after excision. So this patient was HIV negative. We see the diagnosis later, and this is another patient who had these lesions for almost 4 years on the scalp. And the diagnosis, the biopsy was done, and the diagnosis was the same as the previous one. And this is the same patient. And as a physician or a doctor, you can wonder what is this that is coming. And from the pathologist point of view, he said that this is obvious from him because these are fungi that are surrounded by so many macrophages trying to fight, but this was aggressive, and H&E stain looked like this, and further staining with special stains, PAS stain. For the pathologist, this is a characteristic. The Y-shaped figures you can see are characteristic of hyphae for a mycetoma or mycotic mycetoma. And as a quick summary of this disease, it's a chronic subcutaneous fungal infection of the skin and soft tissue, and it is more common in uncovered areas. So, and the most common type is what is known as Madura foot, because it is common in this area in India, and it can also occur in immunocompetent patients. A variant of it is what is called actinomycetoma, but this is not a fungus. It's caused by a bacterium called Nocardia bacillus. And in this case, he wondered why this is on the scalp for his 2 patients, but because most of the time it is on the skin but not on the scalp. This is another slide taken from Up to Date, showing the typical Madura foot, and if in that endemic area, it can be even diagnosed without pathology, because the triad is tumor of the foot with the multiple sinus tracts and the macroscopic grains coming out of the wound. In those endemic areas, they say that this is Madura foot. So the treatment is not so much different. Itraconazole is the most preferred. Other treatments, as you can see, in the same group of, the same family of drugs. So as you can see, one of the patients went excision 3 times with the recurrency. That's why they say surgery alone is not curative. And if you see really that surgery is needed, then you can start with antifungal treatment and surgery later, and then continue with antifungal treatment again for the total being 12 months. So these are the cases here to share. And in summary, as we have seen, it is important to diagnose these lesions when it is still early, because when it is too long, there is a risk of dissemination and the treatment is difficult. And as you see, the role of histopathology is important in making these diagnoses. Thank you very much.
And as we are all of us physicians, we meet these cases most of the time, and it's difficult. But now he has been showing us how the histopathology can be helping in making the diagnosis. And the treatment is simple, so just the tablets you give, and the patient is healed. So this is very important to develop physician, pathologist, and we work as a team and we work together to improve the care of the patients. Thank you very much. So we are going to welcome our last presenter in this morning session, who is Dr. Jose Sebatunzi. So he'll be presenting on post-hepatitis B vaccination immunity status among healthcare workers in Rwanda. And this is very important. As you know, the infection, to be infected with hepatitis B, the risk is very high. And as health workers, yes, we need to know this so that we will not be infected as we are helping the patients. He is now currently the acting head of department in internal medicine at the University of Rwanda.
Thank you very much, moderator. I'm pleased to present to you this morning the hepatitis B vaccination coverage among healthcare workers at a tertiary hospital in Rwanda. This work has been done by a multidisciplinary team at CHUK. As outlined, we start by background, then we see objectives and the rationale of this study, methodology, result, and conclusion. As you all know, hepatitis B infection is a major problem. It's a major public health problem which leads to many complications, including cirrhosis and chronic liver disease and hepatocarcinoma. Approximately 300 million patients around the world are chronically affected by this infection. 500 patients die every day from end-stage complication of this disease. Some study conduct in Taiwan and in India, they suggest that from a non-vaccinated individual can contract just by single exposure to any fluid or any exposure to HIV infection. It has a risk of from 6 to 30% of contracting this infection. We all know that there have been much progress on antiretroviral therapy, but still we have a minority of chronic hepatitis B patients who present with sustained care response. The primary vaccination is key, and it is remain the only effective protective measure. For healthcare workers, they are at risk of getting a hepatitis B infection. As you all know, they are frequently exposed to blood, and potentially they have a high risk of getting this infection. The previous report have shown up fourfold increase in the risk of acquiring a hepatitis B infection in health care workers compared to other general population. In Rwanda, research have revealed that 2.9 of the prevalence of 2.9 of acute and chronic hepatitis B infection among health care providers at tertiary hospitals. From 2013, hepatitis B vaccine were administered to all medical staff as a policy from Ministry of Health, even to other people who work in the hospital, student. This has been a policy, but generally if you try to see the protection of this vaccine, generally there's no need to boost someone who is immunocompetent. But we have some people with high risk, especially people who works in healthcare, some kids and hemodialysis patient. Those people, they have a high risk of developing hepatitis B. As recommended by WHO, the post-vaccination antibody level is generally measured 6 to 8 weeks after vaccination. The major level of anti-hepatitis BS, the protective one, is greater than 10 international unity per milliliter. If you have this kind of protection, it means you have been protected by the vaccine. As we all know, there is no policy, there is no strict policy in Rwanda which indicate that there is a post-vaccination policy among high group, risk group, especially for people who work at the hospital and the healthcare. The result from surveillance could allow the identification of medical staff at high risk acquiring and if need revaccination. Why have we choose this study? This study it aimed to evaluate post-vaccination immunity status and characterize potential risk factor that may be associated with the lack of response among community health workers. The methodology we used, it was an analytical and observational cross study, which was done at CHUK. We included 300 73 health workers, adults, who have received compulsory 3 doses of hepatitis B vaccine from 2013 to 2016. The sample collection and sampling strategy, every patient, every participant to this study have signed a consent form. Then we have addressed to them a questionnaire. The sample size and the way we collected our sample, we collected 3 mils to 4 mils of blood specimen from health care workers at CHK, and then we did serological tests and by using ELISA. Now, the selection was done randomly among those people who has been vaccinated from the period of 2013 to until 2016. The participants were age adult from 18 years and above. And we have we considered the protective level greater than 10 milli international unit. And then when it was less than, it was non-protective. Then, of course, this study has been presented to CHK Ethical and Research Committee, which approved it. Then for analysis, we use SPSS and Q-square for discrete variable, where we considered P less than 0.05 as statistically significant. Now, for social demographic data, the mean age for our cohort was 40.7, and then female were more predominant with 78.2%. As regard to occupation, the most people interviewed or in this study, the nurses were the big in number, and in department, the internal medicine was the one who had 23.9% of participants. Now, as regard to immune response to hepatitis B vaccine and its relation to some socio-demographic factors, we found that we characterize 3 type of variable: non-responsive, hyper-responsive, and hyper-responsive. Non-responsive to is people who had a protective immunity less than 10. Then hyper-responsive, it was between 10 and 100, and more than 100 it was hyper-responsive. And then, as you can see here, we found in our study, the result showed that the people who had been developed immunity equal to 90.4%. There are those with hyper-responsive and hyper-responsive response. By doing the bivariate analysis of risk factor for non-response to hepatitis B vaccine, now we found that the female have were big number who developed this this protection against hepatitis B. But we try to see if the BMI and age, those variables have not been statistically significant. Now, as conclusion of this study, the majority of those vaccinated, 70%, had a high level of immune response. That means they had a level of response greater than 100. And 20.4 were hyporesponder. They had also an immunity between 10 and 100 milli international unit per milliliter. And only 90.6 were classified as nano-responder because they didn't get a sufficient anti-hash-based response. our study show what we have seen, they are similar to other studies done in the world. Now, the anti-hepatitis B response was significantly high in female when compared to male. There were no significant association between decline in antibody level with age and BMI. Then the anti-hepatitis B titer were similar. The group of participants who received 2 doses and who have received 3 doses of vaccination. Our findings provide a basis for testing for anti-hepatitis B in all health care workers in Rwanda, 6 to 8 weeks nation. As we don't have this kind of policy from the Ministry of Health, this can be a recommendation because we as health workers, we have a high risk for developing this infection. I thank you very much for your kind attention.
Thank you very much, Dr. Jose, for this instructive presentation. And as clinician, it's really relevant to us as we are medical professionals. So thank you very much also, dear presenters, as by keeping time. Yeah, we are really on time. So we can just discuss if there's any addings or any question, it's welcomed. Rwanda College of Physicians is a family. We are with our lecturers since the university, senior lecturers, researchers, and colleagues. So we need you to transfer knowledge.
The question is to Dr. Sebatunzi. I just wanted to ask about the non-responders. Would you recommend revaccinating them if you found there were non-responders after 8 weeks? What would be the action?
My name is Dr. Musemakwera André. So, from Rwanda. Okay. And I have 2 questions. The first one is about the first presentation of HIV clinic, or HIV patient. Sorry. So my comment is about the risk of bias, because the mortality rate is very high among HIV patients. And one of the factors is that people attending hospitalization are already biased as HIV patients because they are critical ill. But compared to the patient in general that we have followed for many years, and the mortality rate among HIV patients is very low and less than 10% on the time when I was involved in the management of HIV patients. So from 10% to 28% there is an explanation because there is a bias of selection. And it should be very interesting to compare with the figures of the former track clinic where all HIV patients were followed there. So just as an introduction of this presentation. Thank you. So I go to the last presentation about this very interesting study also concerning hepatitis B and immunoconversion after immunization. My comment is just, I'm astonished because women seem to be better in immunity response. Should be an explanation. Is it because, for example, men are lost for follow-up or in this no discipline? Sometimes they not follow the calendar. They came 2-3 months later, too late for, and they are, that's one. For the women, I don't know why. Discipline, diet or the way of living, no alcohol in general. Is alcohol involved in? I don't know. So that is one issue. The other one is yes. Another question is those bad responders, hyper-responsive. I think it is possible that they are already infected before vaccination, because sometimes people are vaccinated without testing because it is very expensive. Are you sure that all your patients were already detected for hepatitis B before immunization? That should be also another factor, because if you are chronic carrier, probably you don't get immunity. Thank you very much.
Thank you. I have two questions. The first one is the first presenter. What does the HIV mortality represent in the whole CHUK mortality? Meaning, how many people with HIV-related death in comparison to the rest of the whole other conditions in the hospital? Because that is one important parameter to know where we are in relation to the all efforts that were involved. The second question goes to Sebatunzi. I believe you are killing his name. You know, when you say Sebatunzi, Abatunzi are the people who take the cow from Muta to Bushenge and the area. These are Abatunzi. Abatunzi are the one who keep the cows. When you call him Sebatunzi, you're killing his name. Am I right, Oze? You father, so your father called Sebatunzi, not Sebatunzi. So please respect these. Everywhere. So your question is, the question to you is, when you look at the variable you controlled for in terms of the non-responders, I believe we need to take this further, because if you look at the non-responders, yet they are care providers, they are at high risk. We need to go deep and look at what are the other variables. Take that subgroup, look at what other variables we have to look for. Are they on contraception? Are they having other diseases like hepatitis C, HIV status? We need to take that further, because a health professional who is non-responder, who is at his work, it's a risk. We need to take that away. Thank you.
For the presentation about the hepatitis B, I would like to know if there is no relationship between the non-response to hepatitis B vaccination and the duration between the dose, 3 doses we received. Because some people, they missed the dose at the date given, then they come after different days. There is no relationship with this non-response to this vaccination? Other question was asked by the Dr. Msabeoze about there is no other disease underlying to have no response to the vaccination. Thank you.
Thank you very much for the question that I was asked from Dr. Musemakwel. He said that for the mortality rate that I was presenting, it was high, and my presentation was specifically on the year from 2010 to 2013. And what you said is true, that there is a decreasing in mortality compared to what I was talking about. That was specifically from 2010 and 2013. And I agree with you that there is a bias compared to what I talked about. Thank you. And the second question for the mortality rate in Africa for other diseases compared to HIV, there is no studies that is done to compare it, but what I can say is that there is improvement. As we know, in Rwanda, we achieved the goal of 1990 of there is a viral load suppression, which means for the people who are taking antiretroviral therapy, they are improving, and also the mortality rate is decreasing. Thank you.
Thank you very much, Dr. Sugira. And I have some observation other than question. For the first question, for people who did not respond to the vaccination, what we recommended them to be revaccinated. As you know, this policy has been implemented in all health facilities from Ministry of Health since 2013 up to now. Every health care, every health care workers are vaccinated. Even the new people who join the hospital, they are vaccinated. For those 9.6% found in our study, we have recommended them to be revaccinated. The second question asked by Dr. Semakwel about immunoconversion, why women are more protected than men. We have not evaluated in our study other variables like alcohol and smoking. They are also reported in literature that they can also lead to this poor response to this vaccination. We have also some genetic factors which may be included. I think this can also be another topic to be studied. The hyporesponders, if you have been sure if they have been tested for hepatitis B, no, we have not. We are not sure if they have been vaccinated. As you all know, there is this kind of a catch-up which has been done in countrywide, where people has been vaccinated in mass, but without screening them prior vaccination. That's why our cohort has been not vaccinated. But as it is recommended prior to get hepatitis B vaccination, you need to be tested for hepatitis B. Now, Dr. Musabeyezu asked about other variables which can be involved for non-responder. Yeah, you are right. I think this can. We have not evaluated other comorbidity like hepatitis B, hepatitis C, other chronic disease and contraception. I think this can also be studied and see if they have an impact or poor response to hepatitis B vaccine. And last question, it is about if this protection of hepatitis B vaccine is linked to the duration of the 3 doses recommended by WHO. We have not, we didn't go into this, but normally when someone misses any doses, when you miss one for the first dose, within 4 weeks, you can get the second one. If you have missed the second dose, within a period of 8 weeks, you can be able to get the lost doses and be protected. But we have not go into in detail and ask those questions. I thank you very much.
I have not been asked a question, but because of time, I had something to add on my presentation. So these long-standing infections, some of them are on the WHO list of neglected diseases. And the 3 Rio patients I presented, the doctor tried to follow up. The HIV patient later died, and the 2 other patients were coming from Nyamasheke, and the surgeon was curious to follow the patients, and the recommended treatment was itraconazole, and he couldn't find any for his patients. So because we are with the senior colleagues, I can't leave without telling you that, because we're working in referral hospitals, but as you know, we even miss amphotericin B, which is recommended, and even for empirical treatment of aspergillosis we are trying, itraconazole is not easily found. That's why there is a trend towards awakening people about neglected tropical diseases. Thank you.
Yes, I want to know why they prefer to treat for nocardiasis with antifungal treatment, and if I remember well, nocardia is a bacterial infection. And they prefer to use antifungal treatment.
So if you remember very well, I said it's a mycotic, it's a variant of mycotic mystoma, and it was found to be a bacterium, not a fungus. And as Dr. Constance is saying, this can be treated with Bactrim, and as you remember, PCP chain, the fungus, then the protozoa. So if it is specific, then the treatment is also specific.
The next 30 minutes is going to be led by Dr. Muvunyi. Bienvenue. Welcome.
The next session will be on malaria. Malaria is as an infectious disease, parasitic disease that has been affecting the globe for years. In 2018, WHO reports that malaria cases worldwide were 228 million and was killing around 405,000 dead. And Africa is mostly affected because 93% of the cases are in Africa and 94% of deaths occur in Africa. So we can't talk about infectious disease without malaria. Malaria affects more children under 5 at 67%. Pregnant women are affected. But as we saw, HIV patients and people who are non-immune to the endemic area also are affected. For this, that's why we thank the Rwanda College for Physicians for including malaria talk as well and in this symposium. The first presenter is Dr. Emab Bituyumuremyi, who is now working as head of National Malaria Control Program, other parasitic disease and neglected tropical disease, as we just saw. He has 7 years experience working at the Rwanda Biomedical Center. He has been working on HIV and other blood-borne infection and STI, and now is one leading the prevention of malaria control in the countrywide using indoor spreading, long-lasting impregnated nets. So without further ado, I would like the audience to welcome Dr. Emab for the first talk. Thank you.
Good morning. Thank you, moderator, for introducing me. I think I'm happy that I skipped the first slide because I talked about it, but to be presenting malaria situation in Rwanda. Of course, I would prefer beyond, but because of the time, I mainly focused on Rwanda. This slide, as Dr. Bienvenu said, it's about the global burden for malaria, and I think I not delay on it, but you can see that malaria is a global public health issue, but as he said, mainly Africa is the most affected. With the recent report from WHO, we can see that more than 200 million people are affected by malaria every year, and this was in 2018. Even though there is a slight decrease compared to 2017, but malaria still represents a public health concern. For mortality, more than 400,000 people die every year, what also represents another threat for the world. And this is also the same for Rwanda. Maybe when you look at the third bullet, we can see that 93% of the global malaria burden is only coming from the African region, meaning that Rwanda is among those countries which are the most affected by malaria. Of course, we have some factors behind this, including the climate. We have good climate for human. Think about also the wealth of mosquitoes, because mosquitoes also are attracted by a good temperature, but also water bodies. And people also need water, need temperature. You can see that why Africa is mostly affected. Under 5, as we see, are most affected, but also pregnant women. But Rwanda may not be the same case because of key interventions being implemented. But when we look at in Africa, you can see that Nigeria is the biggest country, of course, but representing 25% of the global burden, meaning that it's a real threat in Africa, but also our neighbor DRC is following with 12%. I think these numbers are showing really how malaria is a global burden, but let us look at our country context. This slide shows you the malaria incidence. We try to compare how many new cases we record every year from 2008 up to last year. And you can see that malaria has been increasing, but in 2010, 2011, 12, there was a drop in malaria incidence following some key control interventions. But something happened in 2013. There is a progressive increase up to this highest peak in 2016-17, with almost a half of people affected by malaria in Rwanda. I'll try to go in details about this, but some interventions also included in what we call malaria contingency plan were put in place from 2017, recommended by the government, and we are recording now a slight decrease in malaria incidence, but we are still far from our goal. As I talked about some factors behind, one is the climate change that can justify why malaria keeps increasing, not only in Rwanda, but also in other countries. And you see that when you have temperature increase, when you have rainfall increase, and water bodies increase, mainly this in Rwanda is very key, because with the rice plantation areas, with the mining activities, with the major construction everywhere, other factors contributed to malaria increase. And very key also is about behavior change. It's very important for clinicians to understand, as you receive many people coming to you, it's better also to educate them about this behavior change. Mosquito have changed and became resistant to insecticide that was used for bed net treatment, but also for indoor residual spraying, IRS. This is a key intervention in Rwanda, consisting of spraying an exercise that can last around 1 year. But mosquitoes have changed their behavior and resisting to these two products, meaning that even though the coverage was high, but mosquito were not able to be impacted by these two interventions, yet they are the two ones recommended countrywide. Another factor is the early biting behavior. People, I used to say that mosquitoes are biting late night, from midnight, but recently we discovered that they can even bite from 6 p.m., meaning that you can get a bite even from your workstation. From your office, you can get a bite while you still think that you get a bite from midnight. This is no longer the case, at least in Rwanda. And now we are advocating to ensure that public health institutions or public institutions, private institutions should avail mosquito repellent product so that you can use them to protect yourself before reaching your bed net. Another change is the low coverage in some interventions. Because of this resistance for IRS, we had to shift from those products with the pyrethroid in it, and we moved to a very expensive product with no resistance, meaning that the coverage in IRS dropped from 2013 because of this shift to an effective IRS product. I think these are key factors behind, but this tries to summarize what do we have now as impact on malaria cases following this major effect. These are total malaria cases recorded every year. The first slide was about the incidence, but this is about malaria cases. And you can see that from 2012, we had less than 1 million countrywide, and the blue color shows how many cases were treated by community health workers. And you can see that the proportion was very low because it was only for under 5. But we see this progressive increase in 2013 when we documented resistance to pyrethroid. And you see that also the following year there was climate change in temperature increase and rainfall, and you see that malaria continued to increase up to 2016-17 when we recorded more than 4.8 million a year countrywide. I think you can see that this is a real threat for Rwanda, and even though we introduced those key interventions in the malaria contagious plan, we still have this burden of around 3.5 million last year. Meaning that as a clinician, we have a huge threat in malaria because all districts of Rwanda are affected. Of course, some of them are most affected, mainly in the east and the south, but also in Kigali, because of construction. Remember that, because of mining activities, bricks production areas in Kigali, you can see near Nyabarongo River, where people produce bricks, but also are bringing sand to construct our houses in Kigali, but they are creating big holes of water bodies, which are favorable to mosquito growth. Meaning that what we are doing now is also contributing to malaria increase. But we may not stop rice plantation. We may not stop construction, but we should think about how to put in place key intervention to prevent malaria where we work. This is just a list of key interventions, including prevention. We are recommending long-lasting insecticide net for everyone. Of course, we are targeting under 5 pregnant women and the general population. We also use indoor residual spraying, as I said, but because it is expensive, we are only targeting high burden districts located in the east and the south of the country. Today, the entire eastern province is covered, but also 5 districts of south are now covered with a good impact. Remember, when we look at the trend, we see a progressive decrease in malaria. It's because of IRS in those high burden districts. Another key intervention is the case management, and this is done at community level by community health workers and by health care providers. When I go back, you see this progressive increase of the blue color, meaning that from 2016, following the upsurge for malaria countrywide, the government recommended that we treat also adult people at community level, and you see that now the number is around more than 50% of all malaria cases now managed by community health workers, meaning that we have the whole support from the community level. That is why we may be receiving a few cases, mainly those severe cases, but at least all simple malaria, 57% of them are managed on time by community health workers who are trained on diagnosis and treatment. Of course, we educate people on prevention, and we introduce new tools. As I said, mosquito repellent products are available now so that we can buy and use them while waiting for the bed at midnight. At least you are protected. This is a map showing how we now allocate our intervention countrywide. As I said, the entire east is now covered with indoor residual spraying with bed net. Because it's high burden districts, we combine 2 interventions. And in the southern province, we have 5 districts with IRS as well. Remember that at the global level, more than 400,000 people die every year. But for Rwanda, you can see that when we record this highest peak in 2015-16, we have introduced this early diagnosis and treatment by community health workers. These are volunteers, but they are trained on how to know if we have malaria. They can test and treat if positive. And you see this progressive decrease in malaria-related deaths up to less than 300 a year countrywide because of this early diagnosis and treatment. And this is on progress. We are still waiting for a few months, but it's also a half of this because of these key interventions. I think this can show it clearly with the severe malaria as well. This is about the number of malaria cases. You can see this peak of around 18,000 a year, but as we record the progressive increase of people accessing services at community level, now at 57% from 7% in 2014, you see there is a drop in severe cases, translating early diagnosis and treatment, decreasing the number of severe cases. It's the same with mortality due to malaria. You can see with more than 60% reduction in severe malaria and deaths due to malaria because of the work done by community health workers, but of course with the clinician. And we take this opportunity to thank you for the improved care and treatment of people with malaria. This is my last slide. I thank you so much for your attention.
The next presentation is on, among the intervention we saw, there is prevention, education, but also we also have case management. The trend now is going to the early detection, diagnosis at a community level, but few cases also can come to the district hospital and tertiary hospital with complication including acute kidney injury, cerebral malaria, pulmonary edema, and so on. So the next presenter is Dr. Nsabimana Theonest. He's a physician. He works as an internist at Kibagabaga, one of the district hospital in Kigali city. Is interested in improving quality of life of patients, both for acute and chronic illness, on the diagnosis and management, with the goal of preventing short and long-term complications. He is a trainer on communicable diseases, but also trainer in viral hepatitis management. So today is going to talk about management of malaria cases as a clinician. Welcome, Dr. Theonest.
Thank you, Dr. Mvunyi, for the nice introduction. And I think it will be his task for me after the presentation of the one in charge of malaria in Rwanda Biomedical Center. And some slide has been talked about it. I'm not going to pay much attention on it, especially regarding the epidemiological data. So I think the current situation, malaria globally and locally has been taken, and I'm going to insist about some special characteristics of Plasmodium and the severity of malaria and the related mortality, but also some preventive measures and the way forward. So I think this has been talking about the global burden, around 228 million, and the Africa is one of the most affected with the in terms of malaria cases and the mortality. Rwanda also is not spared, but as he has spoken, the incidence is now being decreasing, even though we stay at around 32%. Here is data from Chiwagawaga Hospital for last year. We also have many cases of malaria, as in the whole country, but the great thing is that the mortality has been decreasing, and it is the same figures as nationwide, countrywide. So let's talk a little bit about Plasmodium, and we know the malaria is caused by parasite that is transmitted to human through insect bite. So when there is an insect bite, it injects some sporozoids that are glide through the skin, through subcutaneous tissue, till it reaches the blood. And within a few hours, it can reach the liver, where it starts multiplication as melozoids, and it can take 1 to 2 weeks for falciparum plasmodium to get involved and to break down. But for some species like vivax and oval can take longer, even months, years within the liver. And when the hepatocyte, the melocyte can up to 10,000 to 30,000 within, and when it breaks down, it invades other red blood cells which are not infected, and this complete asexual blood cycle, which can occur like every 48 for falciparum plasmodium, but also for malaria, plasmodium can go up to 3 days, 72 hours. And this can be repeated several times if nothing has been done. And this can lead to increased the parasite mass and biomass, and which also is associated with the severity of disease. If there is tentative of treatment, but the treatment is ineffective, we can have decreased the level of detection in the blood, and at that time, the symptoms may appear, but later on, the symptoms may occur again. This is the recrudescence, and this can happen at a regular basis, like every 2 or 3 months, and the patient will be present with a repetitive episode of malaria symptoms. So the severity of malaria and the mortality mostly is based on its pathophysiology. And when there is red blood cells are infected, they lack its deformability. And this deformability associated with the cytoadherence, which mostly tend to sequester in venous vasculature. And this sequestration mostly occurs in the brain, and where we found cerebral malaria. But it can occur in other organ like the kidney, the heart, and we can have different manifestation according to area which is affected. And when there is interaction of multiple pathological effect, because if there is rises of red blood cells, is where you can have anemia. But also with the malaria parasites, you can have myelosuppression, and this can lead to severe anemia, which also can complicate respiratory and have distress. And again, with this losses of vomiting, nausea, and the encephalosis that occur with malaria can also contribute to development of metabolic acidosis, which also can lead to respiratory distress. So there is interaction of this metabolic pathophysiological, and it is important to know when you are managing the patient, because this can be associated with increased mortality rate. So based on that pathophysiological, we can have cerebral malaria, acute respiratory syndrome, severe anemia, but also there is another sign and the symptoms which can be detected early in management. So it is be the role of a clinician to know what is the patient is presenting, because not only cerebral malaria or severe anemia, which can be the sign of severity of malaria. So why some people get severe malaria, either is high parasite densities or increased parasite multiplication, which will lead to biomass parasite with catastrophic changes. But also the immunity, the young children and the elderly people are more prone to develop this severe malaria, but also in case of malnutrition or immunosuppression. And we can have antigenic variety and genetic resistance to some people. So differential diagnosis is long, and it can range from bacterial, fungal, or viral infection. Let's talk a little bit about laboratory diagnosis. We know the standard could be is light microscopy, GM staining with thick blood smear. But for blood smear, it's difficult to identify the species because the red blood cells are raised, and it takes time to declare the slide negative because it can go up to 20 minutes to examine one slide. The thin smear is easy and because the red erythrocytes are spared, and it will be easy to identify the parasite. And it is very important because we know some parasites like Vivax and Ovi we talked about are not treated with the usual standard treatment. But also there is rapid diagnostic test. There are two kinds. One is histidine-rich protein. Specifically, this is specific for Falciparum plasmodium. So it has disadvantages because it doesn't tell if people are responding to treatment because it remains positive up to 28 days. So, and again, with this, if the parasitemia drops, the sensitivity also drops. But with high with a high parasite, the sensitivity and the specificity is good. It's around sensitivity of 96% and the specificity around 98%. So another type of rapid test is the Plasmodium falciparum LDH. It's Plasmodium LDH. This detects LDH on Plasmodium, and if the parasitemia level is increases, we can have the positivity. And this can be even used to monitor response to therapy because it is linked to the parasitemia level. So let's talk a bit about management. But for management, I think the general principle is very recommended, especially supportive management. And the easy and repetitive clinical assessment is mandatory so that you can detect early manifestation of severity if the parasite are not keep on multiplicating. So the standard medication here we are using is artesunate or quinine for severe malaria, and for uncomplicated malaria we use artemisinin combination therapy. This some dosage reminder. Let's talk a little bit about prevention, but prevention, it's either it's multidisciplinary team, because it's either about the vector control and in the early diagnosis and the management. And in the vector control, and you have talked about its resistance, and but it's usually to maintain this coverage with long-lasting insecticides, but also this indoor distribution. I think this slide you have seen in the previous presentation. So early diagnosis is very important so that we can cut the cycle of transmission. So thank you very much for your kind attention.
I'd request the two presenters to join the 4 seats and can have a few minutes to get questions. Thank you so much. We've seen how malaria is a concern and how Rwanda, as well as other countries, are doing the fight of malaria, but also we've seen how malaria cases can be managed both at community and health facility level. I think you have comments, questions, so I'll request the one having a question, a comment to introduce, and don't ask more than one question for us to keep time.
Thank you very much. Marigorete Baransabira from Rwamagana Provincial Hospital. I address my question to Dr. Aimable. This is my first time I have the chance to have at home this method used with the population spray, ARS. And they recommend to close about 2 hours. And after when he enter, it was the same time I see the mosquito in the house 2 hours after I open. My concern was, because when they come, they didn't even show us what they are using. Even the concentration, we don't know what is the spray they are using. My question was about we don't know if the concentration is correct. Even the spray they are using, we don't know what is exactly what is it. And this method, what do you think about the method you are using now? Because this is my own experience at home. The second one is about the hospital. When I work in the eastern area, when they spray in the district, the hospital remain alone. And we are always in the hospital. As you see, in the hospital, there are much mosquito inside. There are no other method they give us to prevent ourselves. And when you see at the TV, they said there are other methods you can use. Why don't you give us at the hospital's personnel to use in order to prevent ourselves against malaria? Thank you.
Thank you very much. My name is Menela Sinyeshimana from CHUK, and my question goes to both speakers. I have been seeing that we have been focusing on how to get rid of mosquitoes. As a global health advocate, and one of our core principles is One Health, I think the approach itself is a bit problematic, because we by the end of the day, we know that the life of humans, animals, and environment, they all should be computed in intervention that we do. When we spray these DDTs and other things that we have sprayed in order to get off Plasmodium falciparum, the history will always remind us on the Silent Spring. I don't know if you know the story about the Silent Spring, when they sprayed the DDT to get rid of mosquitoes, and you end up getting rid of everything that was alive in the environment, and that came up with very great consequences. And very soon enough, it was resistant. You did not get rid of whatever you want to get rid of. So I was wondering, at the level of research, what are we looking into that is both friendly to the animal health, human health, and environment, apart from the sprays that we are putting in the atmosphere? And two, we have been waiting for the vaccine for very, very long. And every time that we go on the news, scientific news, they keep telling us it's very soon. So what is very soon? How many years are we waiting for again? Thank you very much.
My name is Musafili. I have just a very small question. Emab talked about all the methods used for prevention, and he added other tools. And I want to be specific with one tool. There is no single family in Rwanda without that tool. This is, I don't know how we call it. It's a liquid with a small container with a kind of, yes, which red, which we plug in. So here I want to come back to the safety. We always use it. It has a kind of a nice scent the whole night, but we don't know what is the content of that fluid, and is it safe for us? Thank you.
My question is addressed to Dr. Imable. You showed up a slide, a nice slide, and I remember that period between 2012 and 13 with the low incidence of malaria. I remember I was in CHUK. By that time, I spent 2 years without seeing case of malaria. By the time I was surprised because we're about to forget to treat malaria in a referral hospital. Then it came back. It increased up to the. I was asking my question, what has been done that time which brings so low incidence for malaria, which cannot be done today?
Dr. Goretti asked about the safety of indoor residue spraying and concentration method, and water repellent can be given to people working in the hospital for their prevention. I would request Dr. Imable to first answer the two questions. Thank you.
Yeah, thank you so much for so many questions. The first one from Dr. Goretti was about IRS. IRS is, as I said, it's one of the core interventions implemented in east and south of the country because of the high burden situation. What you are using there is an insecticide that can last at least 1 year, meaning that people will come to spray in your house only once a year. The concentration, I think, it's more detailed, but it depends on the product used. But what we have used in Rwanda is a Fridora Fusion. It's an insecticide that is in the form of powder and is diluted in almost 10 liters. And before they spray, they should be explaining to you what they are mixing and also what are the precautions to be taken before. Removing all items in the house. If you have kids, if you have a domestic animal, they should be out, and they inform you when you will bring them back. After cleaning all insects that may have fallen down, and it's now when you can go back into your house. I think if they didn't explain to you, this would be an error, but they are educated on how to introduce themselves and on how to spray and also how to make sure that families are following the regulations. I think SBCC is very key before any intervention. Maybe we'll check with the team there because they are community health workers who are spraying and they are communities around. But of course, we need to train them every time. About the safety, we use only products that are WHO pre-qualified only. And without this, we can't introduce them in Rwanda for the public health use. When you check on the website on WHO, you can find Fridora Fusion. You can check Acteric. You can check Bendiocarb. Those are products we have been rotating from 2014, 15 up to now. Bendiocarb, Acteric, now Fridora Fusion. These are WHO pre-qualified. And they are safe once properly used. Of course, when not properly used, as any other product, it can be harmful. That's why they are even protected, those sprayers, they are protected, and they educate people when spraying. For hospitals, it's true that it's a threat because we have a patient there, and we also have healthcare providers who are at risk. And what we do with in collaboration with the hospitals, maybe Dr. Bienvenu know that, we keep receiving requests from hospitals that they need bed net for all the inward department. I think this is one measure recommended for all hospitals, at least to protect patient. But for healthcare providers and other people coming to visit their patient there, they are not really protected. That's why we are advocating for mosquito repellent, because we can't find a mosquito net for people staying outside. You can't find a mosquito net for a nurse or a medical doctor just walking every hour. What we recommend, just mosquito repellent product that we can put on your skin so that you can get protected every time. And we are just introducing them through social marketing because they are not procured by the program, but it's through social marketing. And I think is really served. You can put in touch with the people selling them. They are not really expensive. One lotion can last 1 month, and it's really affordable. It's less than 100 francs for one month. I think it's not really expensive. What we are also exploring to introduce is wall paint. Wall paint are coming soon. Maybe it's like the vaccine. When is soon? But we are working with manufacturers so that we can introduce mosquito repellent, but also killing paint that can last for 1 year. And after 1 year, it stays as a paint only unless you replace it. I think this would be one of the solutions that can be used for hospitals, for even public schools, with the boarding schools, even for our household, we can use those wall paint. The second question was about, from Melas, about spraying using DDT. For now, Rwanda is no longer using DDT. And even for agriculture purpose, it is no longer recommended, because when you use it, you are not allowed to export your product, and Rwanda is exporting our agricultural product. We are no longer using DDT, but you are using other insecticide. And for IRS, we have been using pyrethroid-based insecticide. In the years, I combined it with Dr. Constance's question. In 2010, 2012, we're using pyrethroid-based insecticide to spray. These were effective that time, and there was no resistance. Remember on the slide, I presented the resistance that came in from 2013-14. And this resistance created a huge gap in the coverage of IRS, because we had to shift to Bendiocarb that is 10 times more expensive than pyrethroid. Of course, the coverage should not be the same when you don't receive the double of 10 times the budget initially provided to the Ministry of Health. I think this is a financial gap that created this low coverage. But today, what we are spraying as the Ministry of Health is indoor. We are not expecting bees in our house. At least we have flies, and we should be killing them because they are also harmful. But outside, we are not using that product. That's why we are only recommending IRS, insecticide, indoor residual spraying, meaning that it's only inside the houses. But outside, we have also other recommended products that can be used. And what we are introducing soon is larviciding. I think next month we start using drones to spray in water bodies to kill mosquito larvae at their early stage. This also will help us to control mosquitoes from the source, and the product recommended is not harmful because it's made from the bacillus. I think these are just few answers I can provide to the second question about the safety of the product.
To be quick, Dr. Musafiri asked about the repellent.
I have noted it, yes. From Dr. Musafiri, I talked about other tools, and I talked about mosquito repellent products. They can be of different types. And the one you talked about, you plug in, is one of the mosquito repellent products. But when you try to smell it, you can either smell like, do you know what is muchai-chai? Yeah, these are mosquito repellent plants, and they extract the essential oils from them, and they can produce different types of mosquito repellent products. But also we have some lotions, we have some coals that can be burnt in the sitting room, and they can only repel. They're not killing mosquitoes, they are just repelling them. And when you remove it, mosquito will come maybe after 2 hours. And what is now recommended is using them where you don't stay longer, because breathing this smell is not also good. You can use it while sitting on the balcony, but waiting for the bed, you have the bed net. Don't plug it in your room. The entire night, this is very harmful. And you'll be receiving, mainly pediatricians will receive children with respiratory disease because of this product. They are intended to be used in the balcony or sitting room while waiting for the night to repel mosquitoes before you get into your bed, where you are now shifting and use your bed net. When you plug it in your room, ensure that at least you have 2 hours before you go to sleep, so that the bad smell can be out. Otherwise, yeah. But for information so far, this one you plug in is not yet validated or approved by the Ministry of Health, but we have other products that are already on the market, and we can share the list, and as we said, the press release, so that we can know which products are recommended. From Dr. Constance, I think I tried to talk about it. It was about the last experience. As I said, mosquitoes of 2010 in Rwanda were not yet resistant to insecticide. This is one. Mosquitoes in 2010, 2012 have not yet changed their biting behavior. While biting midnight, now they are biting early, the evening time. Mosquito in 2012 were not able to bite animals, but when they come in your house, they see that we have insecticide inside, they go out and survive outside by biting animals. And when you stay outside without protection, they can now mix you and animals, and they can survive. I think this roughly some changes, but key is about also the low immunity following this success. When you spend more times, many years without infection, you know that you are losing your protection, and people became also low immune or protected because of this period of success without malaria, and now we are also recording these huge changes. I think roughly I can also conclude on the resistance again. as I said, we had to shift from the affordable IRS product to expensive one, from pirated ones to Acteric to Fridora, more than 10 times expensive, meaning that the coverage in some interventions will dropped. I think this is another key message I can provide to you. And of course, bednet we're still using are produced based on pirated, yet we have this documented resistance till last year when we are receiving new types of net with other insecticide. I think from the last 8 years, we have been using bednet with the pirated, even though we had this documented resistance, but worldwide, no other solution to be used for bednet were available till last few years. I think now we are approaching the resistance mitigation by introducing new types of net in Rwanda. Thank you.
Another round of applause to our presenters. Thank you so much. And thank you, the audience. We now pass the time to the Vice Chair of the Rwanda College for Physicians. Thank you.
Now can recognize the presence of our guest of honor who will speak after the remarks of Prof. Bavuma on this symposium. He is Director General of Clinical Research at Ministry of Health, and he's Dr. Zubair. A round of applause to our guest of honor. Dear guests of honor, this morning we have discussed several topics around infectious disease, and we had a very pleasant morning, entertaining and very rich in discussion. We had like 5 presentations, and the first session was around research in various infectious disease, where we had the research on HIV, just outcome of HIV in terms of mortality at CHUK, and the second was fungal infections topic, and the third one was coverage of viral hepatitis B vaccination among healthcare providers at CHUK, presented by Dr. Oze. And that session was really interactive and very rich and raised discussions that I think will continue even in the break tomorrow and the day after tomorrow. So we had the second session around malaria, where we had a very interesting, I can't call it a wedding, maybe a marriage between clinical practice and public health, where we had a very interesting talk on the side of RBC in terms of interventions, public health interventions, and the aspects or updates of malaria in our country and across the region. We had also a very interesting talk of Dr. Theonest from Kibagabaga Hospital, just experience of a clinician in treating malaria cases, and most of the time they are severe, which came to him. And it was there you find us just discussing, answering questions, and it was very good. So this is the time now to announce the speech of our Rwanda College of Physicians President, Prof. Bavuma, who has prepared for us welcome remarks, and will invite our guest of honor, Dr. Zubel, Director General of Clinical Services at MOH. Prof. Bavuma, the floor is yours.
Dear guest of honor, it's a pleasure to have you here, and you are the most welcome with us. Dear distinguished guests, we are honored to have Professor Andre from Radboud University, Netherlands. He's coming from far to join us, and we are very happy to be with you. You are welcome. We have stakeholders from Rwanda Biomedical Center, from the Ministry of Health. You are the most welcome to be with us, and we are very happy to have you. Sometimes it is very important to interact, stakeholders and clinicians. We have the same goal, actually. It is the well-being of our population. And it is very important to sit together, to have time to sit together, to see what are we doing to reach our common goal. Dear colleagues, physicians, dear pharmacists who are with us, allow me to warmly welcome all to this event, symposium. I think it is the first symposium we have here. It is very important, even if we have reached, we have great achievement in HIV, malaria, and other chronic infection, but we have other emerging life-threatening infection that we have to fight together. Actually, Rwanda College of Physicians was established in 2012 following the call from the Ministry of Health for the use of innovative strategies to maximize health professionals' contribution. So up to now, we have almost 175 physicians in the country, and all are potential members of RCP, but we have only 75 who have committed as effective members of Rwanda College of Physicians. And Rwanda College of Physicians is a great workforce for health system in Rwanda, as other professional bodies. Dear DG of Clinical Services, colleagues, ladies and gentlemen, today we are sitting together to talk about chronic communicable diseases such as HIV. We didn't have articles for tuberculosis, but it's still a challenge, and we are fighting for it. But we have new infection disease outbreaks such as coronavirus, which we have to fight together. And I thank you very much, DG. I know you have a very busy agenda on this particular infection, which is concerning for the global, which is a global concern and national concern. Thank you very much to have a time to come to sit with us. We will talk also about antimicrobial resistance, which is a very concerning, globally, very concerning issue, and prescription of antimicrobial agents are very concerning also nationally and globally. So Professor Andre has joined us. He has trained almost 10 physicians about antimicrobial prescription and antimicrobial resistance. And we thank you very much for that. And we hope for future partnership toward that area. So at the end of this symposium, each and the other of us should be able to fight against coronavirus, which is a very concerning infection today. So we should go back with a plan for prevention of this threat wherever we are working. Prevention of coronavirus is not only at the high level, but wherever we are, we have to have a plan to fight against that threat. So dear DG, allow me to invite you on the podium for your knowledgeable opening remarks. I'm sure that they would like to hear from you especially the plan you have for coronavirus and other plans as you are heading the clinical services in Rwanda. So thank you very much, and you are welcome all.
Antimicrobial resistance and the rational use of medicine, including antibiotics. So the Ministry of Health, which I represent here, is really very pleased to participate in this very, very important event, this symposium. I was supposed to be somewhere in one quarantine site we are setting up, and which is due to start operations very, very soon. If not tomorrow, at least in 2 days. And of course, the facility cannot work without your contribution. You are the one who can guide, who can contribute. I have seen our colleague, some of our colleagues are participating in an advisory committee for this particular health threat, coronavirus. So, this symposium came at the right time. And the discussion you are going to have here will for sure help us to draw the guidelines you are talking about, the plan you are talking about. So we can do as we feel it, but we are not going to be successful without your contribution. Because you are the specialists, you know very well how to manage at least clinical management of if we have a case, we will definitely need you, your expertise, your knowledge. So I was supposed to be there, but I couldn't miss this opportunity given to me as the DG of Clinical Services to come and interact with you, with the physicians. I believe you are the one to manage the highest percentage of overall numbers of patients we have in our hospitals, public or private. So that is very obvious. So probably you are the most solicited doctors in Rwanda, even in the world, I don't know. Because you are managing infectious diseases, you are a physician, even non-communicable disease, Professor Bavuma. I know you are very, very, to have an appointment with her is very difficult. She has a long queue of patients waiting for appointment. So this is very, very important to have the College of Physicians be active and more active than before. So today you are very active by organizing this symposium. We are going to discuss research, new innovations, new approaches, and most important, you can really network together. If someone in Ruhango Provincial Hospital has a problem, how to solve, how to fix some challenges, of course, related to your profession. So maybe when you meet here, you can interact with someone in private practice or in another hospital, or people like Professor Dr. Andre with long experience. So this is a very good opportunity, and we are really very happy to be part of it. Again, it is good to invite other stakeholders like RBC, malaria program, HIV program, other program. Why not TB or other programs? So it is very important. Now, we have our new newborn, Rwanda FDA. Yesterday it was a newborn, but today I think adolescent age maybe. It is getting mature. And they are very important about rational use of medicine, antibiotics. That is very important, just to avoid unnecessary resistance. And it is actually their role and responsibility to regulate the use of antibiotics and such products. So I think all conditions are set now, really, to start good discussions, and recommendation from this symposium should be an asset or something the Ministry of Health regulating the sector, including your sector. So we should borrow your recommendation really to inform or to orient future regulations around the infectious disease management, guidelines. Last time we had this many meetings about scope of practice and what again? We discussed with you about service package. And again, why not? If you have time, you can also discuss the patient trajectory between the public, the private. You know, the law on dual practice is due to be implemented. So how do you practice even that new scope? Dual practice. I'm talking about dual practice. We have got orientation and instructions. The law is there. We are aiming at providing the best quality services to our patients. So you can discuss all of this and draw clear and strong recommendation to help the regulator, the Ministry of Health, the RBC, Rwanda FDA to develop or to propose better guidelines, better regulations around the management of communicable infectious disease. Last but not least, so considering the new era of the fourth industrial revolution, I think the College of Physicians should not be left behind. We need also to see how do we interact with the patient using technology. Physician engagement. How do we interact with the patient now using the technology? How Dr. Beata from Western Province can interact with someone in Lagos. Who is in Lagos? I don't know. So if you have, for example, yes, I know who is there. So if you have, for example, I don't know, a result you cannot interpret yourself, or you need some advice how to manage this or that. So think about telemedicine. Think about digital, electronic medical records. Think of how to engage your patient using. How can you, for example, share results of a patient or communicate to the patients? How do you communicate using digital tools, digital technology? So I don't know if I have enough time, but this also is something we can think about and propose some recommendations. And coming back to the rational use of medicine, I know Rwanda FDA is developing a traceability tool, for example. So what is our role? What is our contribution as a physician, as people monitoring or treating patients every day and prescribing drugs? So what is our role and what is our contribution? So I don't want to bother you with a long speech. So really, this is something we needed. This symposium was really needed. And they take advantage. This is like an event that can happen once or twice a year. So let's have the best we can have from it, and we communicate. We share with those who couldn't be part of this gathering. We communicate with colleagues around the region, in the region, and why not around the world. Thank you so much, and if you have time again, try to know what is going on in terms of for preparedness against this the new health threat, the coronavirus. So, but you asked me to also to give a brief, a summary. There is a national committee. There is a national core team. The chair is the DG RBC. And what we have been doing in the last few days is to screen people, mainly at the entry points, including the airport, screen them. And if for those meeting some criteria for testing, the samples are taken and tested at the Rwanda National Referral Lab. Of course, up to now, no positive results. Thanks God, and we would like that to continue. But you never know. Maybe we can have a case. That is why we have been setting quarantine, isolation, and treatment sites. For now, we have 2. One is in Kanyinya, it is close to Kigali, it is in Nyarugenge district. Shorongi Kubahazi. The other one is in Kabgai. So for quarantine, for isolation and eventually treatment. And we have staff ready, but again, all of you should be on standby. Anytime we can call you and ask you to come and join and support us. Mainly you, physician, you are highly needed for this exercise, if there is a need. And we are due to start really to activate quarantine, the true quarantine, in 1 or 2 days or 3 days maximum. Okay. Of course, we have also other sites in the city of Kigali, mainly for some particular people. Some people like Professor Andre. If you have to isolate you, of course, we are looking something like a Marriott hotel for you. so, but also this facilities are also getting ready. So over the weekend, should declare that we are ready really to activate the quarantine according to the guidelines of as edited by the WHO. Of course, we have some challenges. The first challenge was of course the budget, but that one is being fixed because, okay, I said there is a core team, but all institutions are involved. Security, finance, judicial, everybody is really is concerned, and at a very high level, they are coordinating. The coordination is even at a very, very high level. So we are getting ready, and everybody is concerned, and you are part of the system. So anytime, wherever you are, whatever you do, if you are not sick, you can be called anytime to support. But there is no case. I am told there is another case in Nigeria, but no case in the region, no case, of course, in Rwanda. Thank you so much. And to finish with, on behalf of the Ministry of Health, recognizing the importance of this symposium, we declare this symposium officially opened. Thank you.
Dear Director General of Ministry of Health, and we can join the the audience.
The World Health Assembly drafted what they called a global action plan on antimicrobial resistance. And this global action plan was presented to member states, and they decided that each country, each member state would have what they call a national action plan to fight antimicrobial resistance, which would use as a template, and a global action plan for antimicrobial resistance, and be customized to countries' specificity. So one of the specific nature of this national action plan or the global action plan is to use what they call the One Health approach, where they have to integrate the human medicine, the animal medicine, the environmental issues, all those that are affecting, at the end of the day, that are affecting the humans. So in this line of developing a national action plan for Rwanda, there's a work that started back in 2018. And actually, what we're supposed to do is all member states committed that by May 2013 they should have a national action plan, which wasn't done in Rwanda and in many countries, but there are some other countries that have their own national action plan that they are trying to implement. So back in 2018, when we started working on this, this is a multi-sectoral sector approach that was being used, and it was the initiative was led by the Ministry of Health, and still now it's led by the Ministry of Health under the clinical services. But it includes different stakeholders from different backgrounds. We have agriculture, we have health, human health, animal health, we have environment, and we have different stakeholders in the regulation sector. We have different stakeholders in the private sector, in education. So all of these stakeholders come together to try to work on what they call this national action plan. So of course, what we started to do is to see what was the situation in the country with regarding the issue of antimicrobial resistance. And we did some situation analysis, and we looked at the strength, we looked at the weaknesses, we looked at the opportunities and threats, and we realized that some documents, in the health sector, health policies, health strategic plans, they are already talking about antimicrobial resistance. And we realized also that there's a strong commitment from the government of Rwanda to counter the issue of antimicrobial resistance. And we also realized that there are already some initiatives that are in place and that are working well, that can be used serve as a good basis to implement the programs of antimicrobial resistance. We know that already we have a certain network of laboratories that are working under the National Reference Laboratory, which is very important in the surveillance of disease. And we know that there are different programs in the Rwanda Biomedical Center on TB, HIV, and malaria that are working so hard to make sure that treatments are effective and there's no resistance to the products that are being used. We know that there are the vaccination programs in Rwanda that are working already, and there's some sort of coordination between different entities working in different sectors that we focus on this antimicrobial resistance. So we realized also some weaknesses. including the lack of awareness campaigns about the issue of antimicrobial resistance. And most of other activities that are being done, some of them realize that they are inadequate action about those activities. And we realize that there's an issue of inadequate regulation of the use of medicine, antibiotics, whether it's in human health, animal health, agriculture, the way it's being used and the regulations in place, they are not really adequate. There's a lot of things that needs to be done to work on that. We realize that IPC programs are in place, but are they working perfectly the way we need them to be working? What we have, do we have enough financing system to ensure the program that we want to put in place can to be sustainable? Those are some of the weaknesses the participants looked at. Then we realized that there are some opportunities, including, of course, international organization commitment. We know it's going to be a national plan, but at the same time, the national plan that is going to feed or into the global agenda. So we need the intervention of not only national programs, but to work with the international programs. We know there's different platforms that we can use, media platforms that we can use to raise the awareness about the issue of antimicrobial resistance. And we know also that we can use, we can take advantage of different public-private partnership initiatives that are being implemented in the country. Those are opportunities that we thought we can use. So threats, implementation, even finishing already the plan is still a problem. So we're thinking about the implementation, limited for full limitation for full implementation. We realized that there's a problem of emergence of resistant strains, and we have an increase of resistance and a decrease of maybe new molecule of antibiotics that can help us in the treatment. It's a big problem. The promotion of use of antibiotics agents for animal growth was also identified as a problem. When it comes to the regulation, when we are looking at the issue of substandard products, medicine, fake medicine, counterfeit medicine, even though we know that the work our regulatory authorities have to do is already huge, but when you also consider the issue of porous borders where the illegal trade of medicine can take place, we also realize that's a problem. So those are what we looked at as a situation analysis, but then we started talking about the development of the National Action Plan. The development of the action plan, as I said, there's a global action plan to fight antimicrobial resistance, which countries are trying to domesticate, and even the national action plans are trying to follow the template of this global action plan. So it has 5 strategic objectives. One is to improve the awareness, which is a problem. Another one is to strengthen the knowledge and evidence-based through surveillance and research. I think we've been talking about this in previous presentation. Another one is to reduce the incidence of infection through effective hygiene and IPC measures. Another strategy is to optimize the use of the antimicrobial agents that we have already. and to assure sustainable investment through research and development. So when we are trying to develop this national action plan, so we looked at these strategic objectives, and we looked at the issues we have in the country, the situation analysis, and we drafted some key priorities that can be done to try to reach these objectives. So going with objective number 1, to increase awareness of antimicrobial resistance through communication, education, and training. We know already that we have a lot of behaviors, human behaviors, that we do, but we don't know the consequences on the issue of antimicrobial resistance. That's why we think that creating the awareness, it's very important that people understand the issue. So the issue we're talking about, understanding the social behavior drivers. I think with the different outbreaks that we are facing right now, we understand that to work on the issue of social behaviors, we're trying to find a solution of the issues we are facing. It's really a problem. So awareness, education, communication, mobilization is key in if you want to achieve our objective. So these are just different type of awareness material that we see on the net. I've put them here just to try to, for the audience to think if we ever see this type of material. If we don't see this type of material very often, it means we have a problem in our awareness campaign about antimicrobial resistance. Priorities. Those are different type of activities. I don't know if it's clear enough. Each objective has some activities that the participants, who are the people who are working on development of the National Action Plan, have drafted, so that it helped them to answer the question raised by the objective 1, which is the awareness. So there's an issue of developing programs. We have to develop program strategies on based on health professionals and populations. We have to develop or even institutionalize awareness campaigns, such as having at least 1 week, let's say 1 week in a year, to talk intensively about antimicrobial resistance and how we can avoid those issues. And yes, we have to estimate. We also have to estimate the awareness and knowledge through behavior studies in different professional groups. What we have and what do we need to step up. So includes antimicrobial and related topics as core components in professional education, training, certification, and development. We have different platforms we can use. We can use the undergraduate or postgraduate programs, but also we can use our professional bodies through different type of certifications that we provide to the professionals, components of antimicrobial resistance. Yes, establish also a national coordination structure for surveillance of antimicrobial resistance. I think this will come also in the objective of the program for surveillance of antimicrobial resistance. But we in awareness, we need also have in place a coordination structure that will be only in charge of the awareness. So the second objective was antimicrobial resistance surveillance and research. We know how critical is the surveillance programs and the research programs. We need them to be really effective when we're talking about the antimicrobial resistance. And this is not only from humans or food animals, environmental sources, but it also needs to coordinate, to talk to each other's different programs in different sectors that needs to be put together or coordinated to be able, when we have a system in place for humans, for animals, or for even food, how do we collect the information? How do we analyze the information we get? How do we share the information? And there are different regional surveillance programs. How do we get shared information of what we have in our country with what we get in the region? And how do we get access to what other people have access to in the region? And then the challenges of the facilities, capacity to use microbiology to guide the treatment and perform laboratory testing, and lack of data sharing and coordination. So what are the activities that needs to be done to improve the awareness? So we thought that it was important to integrate AMR surveillance activities in epidemic surveillance or response system in veterinary, human, agriculture, and environmental. Integrate all different sectors. Reinforce the surveillance and monitoring across humans, animals, and food based on data linkage by review AMR surveillance and monitoring tools. Institutionalize a comprehensive think-tank organization of antimicrobial resistance in health facilities. So the other one is to conduct an assessment on the current situation of the AMR in the country and analyze transmitting factors. This one is also very important, is to strengthen the lab capacity for the surveillance. What is going to be done is to assess the existing capacities of our laboratories and try to build the capacity by training the people, by having the necessary equipment in place, but also focus in these other areas that have less resources, because we tend to focus on human health in our hospital, in our national reference laboratories, but we don't know exactly what's going on with in animals. And so if we have also to have a designated laboratory for antimicrobial resistance in place, we also have to put in place training, mentorship, and supportive supervision for personnel, develop the master list of the material reagent items required for surveillance supply mechanism. So you understand that all these activities, that's way coming from the people who are really working on this. Okay. Yes, it's coming from the people who really are professionals in these different areas and who understand what is missing to be able to put in place to implement this national action plan. So on the research and development side, it's we realize that it's important to have a data repository for everything that goes with antimicrobial resistance. but also to organize a national AMR scientific symposium. It's good that we have one already today. We hope that we can have many more in the coming days. And yes, to have a national AMR data repository. So activities were identified also for infection and prevention control. And in this one, we talked not only about the hygiene and the IPC measures in the healthcare community settings, but also we talked about the issue of waste management, which is also important. And then there's the other objective, which is the use of antimicrobial agents in human and animal health. That's where we see issues about the prescribers, issues about the dispensers, issues about consumers, issues about the regulation. At that time, we didn't have the Food and Drug Authority to enforce the regulation, the use of the antibiotics and the other microbial agents. But now it is there, it's in place. Legislative and policy have improved, but now it's all about how we perform and the capacity we have to perform our activities. So on the part of sustainable investment in AMR, of course, financing mechanisms are important. Research and development on how we improve, on how we perform our activity is very important. So on financing mechanism on how we sustain the capacity, equipment, laboratories, training, right? All of those aspects are important, and people talked about this. So I want to say a bit where we are right now. The situation analysis was done, and activities were outlined, what we need to be done, what we need to focus on. And this is just part of the strategic action plan we have. But now, I think maybe in 3 weeks, there's a team also coordinated by the Clinical Services Directorate in the Ministry of Health that will be working on the operational planning and the costing and the funding of different activities of this action plan. And then we look at, once we have the strategic plan, operational plan, and the monitoring and evaluation on how we're going to monitor what we do, we will have a full, complete plan which we will have to implement. So right now, again, another thing I can add on is that we have One Health multi-sectoral coordinating mechanism, which was one big recommendation to be able to have a governance system that will help to drive everything that goes with national action, antimicrobial resistance plan of action, and that is his role. He's the coordinator of this mechanism, is the DG of Rwanda Food and Drug Authority, but all the sectors that I've talked about earlier are represented there. And in this mechanism, they have subcommittees. Each subcommittee will focus on different objectives that we talked about for the development of this national action plan. Thank you.
Thank you very much, Edward. It was a pleasure to hear from you. For our next presentation for today, we are honored to have Prof. Andre van de Van, who I hope I pronounced it correctly, who trained as a medical doctor from Ghent University and Antwerp University in the 1980, and where he graduated with an honors degree. He had a diploma in tropical health hygiene, in tropical health, in the Hygiene Tropical Institute of Antwerp in 1981, where he graduated with honors as well. He practiced as a medical doctor in Botswana for 6 years, and he's in the Registry of Internal Medicine and Infectious Diseases, he was in the Registry of Internal Medicine and Infectious Diseases in Netherlands in 1993. He went on to have a PhD in adverse reactions of cotrimoxazole in HIV infection, where he graduated with honors in 1995. He served as director of the Dutch Research Network for Poverty-Related Diseases in 2005 and is currently professor in international health, Radboud University, where he's also head of infectious diseases at the same university, at Darbourg University Medical Center since 2010. We welcome you.
Just to wind up, that is Alexander Fleming. He got a Nobel Prize because he discovered penicillin. And as you might see, he discovered it because this was at that time is a blood culture and a blood agar plate, and this is Staphylococcus growing on there. But when you leave this on the plate for a long time, after some time you get fungi growing there. And what you see that once the fungus starts growing, then you see that the Staphylococcus starts disappearing. So actually, that was not discovered by Alexander Fleming, but by the lab technician. And he repeatedly reminded Fleming, listen, this fungus makes something that kills the Staphylococcus. You have any idea what is the name of the fungus? The name of the fungus is penicillin. So what is an antibiotic? An antibiotic is a product of a microorganism that limits the growth, kills other microorganisms. So antibiotic resistance is a natural thing because that's what microorganisms do to fight each other. Alexander Fleming was a very visionary man, but he also predicted, if you read this sentence, that antimicrobial resistance formation may develop if you misuse it. Unfortunately, I think he is right for that. So this is also an illustration, because then the war came, and then you had wounds, and then people were treated with penicillin. And at that time, you could treat a staphylococcal infection with 500,000 units of penicillin. While when we treat now people with pneumococcal pneumonia, 4 times a million or 4 times 2 million for 10 days. And that was a single shot. So the microorganisms, they were very sensitive to the penicillin. And this is what you see over time. You get the resistance formation in the hospital, and after some time, so this is the penicillin resistance against staphylococci. So in the beginning, all the staphylococci were sensitive to penicillin. But when they start using it, you see in the hospitals, you get a resistance against penicillin. And after some time, you also see it in the community. So when you start using a lot of antibiotics within your hospitals, after some time, you will see this resistance also within your communities. And then you have a big problem, because then the patients come already with a resistance microorganism. So if you want to talk about antimicrobial resistance formation, this is actually the bottom line. It has been going up steadily and it has become a really big problem. What is the problem? Most of the empiric antibiotic choice are incorrect. So antibiotics are misused. They are given to patients with viral infections. The problem is if once you have AMR, your empiric choice, I don't know how it is here in Rwanda, but we have empiric treatment. Recently we had to change it because the level of resistance of patients coming in the outpatient department or to the emergency room was too high to still use our regular treatment. So your empiric choice may not be correct. Mind you, all the second-line treatment is less effective. So penicillin, just the pure penicillin, is doing far better than meropenem for a streptococcal infection. So your second choice, your third choice, your fourth choice are less effective drugs, but unfortunately far more expensive. They're really expensive. Surgical prophylaxis become ineffective. So you're doing a regular operation, people getting an infection as a consequence, difficult, longer hospital stays, more complications, or, and that is what I've been seeing the last year, we had 2 patients, they were transferred. One was from Italy, he got a car accident there. One was transferred from Southeast Asia. They came to our hospital. That patient died because there was no antibiotic we could treat the patient with. So they had a fully resistant Klebsiella infection. This I've never seen in my whole life. So, a global action plan, the previous speaker discussed about that. That is becoming extremely important. And all the countries are now asked also to implement a global plan. So the WHO recognized that, and then the United Nations discussed it, and all the world leaders agreed to that. We should have a global action plan because this is threatening global health. So all the countries are supposed to implement this, and every time the G20 meets, so it's the leaders of the most rich country in the world, antimicrobial resistance is always on the agenda, just to mention the importance of it. So this is how the picture looks like. Some countries, they are red, they have no plans started. The other ones have started, and when you are very dark green, you have a plan in operation. It's very nice to hear that Rwanda has a plan being developed. Now, why is that? Because when you use antibiotics, you get what we call the superbugs. And they are usually Klebsiellas, and they are producing ASBLs. They are Acinetobacter. So there's a specific list of bacteria which are likely to get to acquire resistant genes. And this is the expectations for 2050. That's every 3 seconds somebody will die from antimicrobial resistance if nothing happens. And the continents which are most seriously affected is Asia, with 4.7 million people, and the expectations for Africa, 4 million people per year. So 4 million people per year. Excess mortality, so we're not talking the regular death rates, but excess mortality related to antimicrobial resistance. So, and the overall mortality, as is outlined here, will be larger than cancer. So we are facing a big problem. It looks like Europe is doing not so bad. Why is that? How is it possible? Can we maybe learn something? Are there lessons from Europe? Now you see that in Europe, so this is about Staphylococcus aureus, resistance to methicillin. So this is the MRSA. And then you see in the southern part of Europe, it's red, that means it's very prevalent. And if it is green, it's better, and when it's dark green, then it's less than 1%. And there's a very small country there, it's the Netherlands, and apparently we are doing not so bad, because we have less than 1% resistance to methicillin. The question is why? Well, this is also Europe, and this is the antibiotic use. This is the total consumption from antibiotics, and this is the resistance from pneumococci. So whether the pneumococcus is still sensitive to penicillin. And when you see, when you have a lot of consumption of antibiotics, like France, you get a very high resistance rate. It's 45%. So when you go to a hospital in France, you get a regular pneumococcal pneumonia. In the Netherlands, we treat that with penicillin. They have to use ceftriaxone or maybe even alternative treatments these days. Spain, similarly. High antibiotic consumption, high resistance rate. This is less resistant rate. So what here you see, the Netherlands, so this is where I come from, we use very little antibiotics. And you might say, that's a very nice country. All the doctors, they let people die because they don't treat them with antibiotics. That's not the case. If you're looking at the quality of healthcare system, the Netherlands is regarded as one of the top 3 in the world. So we're doing actually very well. But we are very restricted with prescribing antibiotics. We are very restricted with that, and we have always been doing that. Maybe it's because we are known to be a bit stingy, so we don't like to spend money for nothing. So why give somebody an antibiotics which you pay for and it doesn't work? Why would you do it? A large variation, Here you see Greece. They use a lot of antibiotics. Do people in Greece have more infectious diseases? No. Here it is Romania, Cyprus. It's always the people, it's always the countries in the south of Europe. Well, if you go up here, in the Netherlands, we use very little. Why? The previous speaker also talked about behavior. So, it's a behavior. It's a behavior of the doctor, but it's also behavior of the patient. When a patient in the Netherlands goes to the point 1, suppose somebody has a running nose and a bit of fever. Sanitation and hygiene. Some countries have no toilet facilities. Not everybody has access to clean water. Antibiotics in agriculture. Vaccines, surveillance, extremely important. We come to talk about it. Rapid diagnostics, the access to rapid diagnostics, human capitals, drugs, and there's a global innovation. So I'll discuss these various issues. So point 1, public awareness campaigns are effective. So they start doing that in Belgium now, and it works. So if you do campaigns on public awareness, yes, it has effects, it has been shown. But also public awareness should be given. Antimicrobial drugs given over the counter without a prescription. So you can just go to a pharmacy or go to a small general dealer and ask for ciprofloxacin, and you just get, you go in Indonesia, you say, I want 2 tablets of ciprofloxacin, buy that, and you take 2 tablets, and So people use it when they have a hangover. They take 2 tablets of ciprofloxacin. I'm not joking. I'm not joking. I don't feel very well today. Let me take an antibiotic. Yeah, you've been drinking too much last night. And it's very common. You can do whatever you want in the healthcare system. But if you do not regulate this, it's impossible. So, antibiotics without prescription, it should be limited, or actually, I think it should be forbidden. It's not good. Improve hospital hygiene. This is the Brian and Hospital. It's one of the most famous hospitals in the world. If you read in the New England Journal, their case reports, they are there. So you think this is one of the best hospitals in the world. You see, which is not forbidden. It's forbidden in the Netherlands. Long sleeves. It's not forbidden. You have to have short sleeves. You cannot wear, because you cannot wash your hands properly. So people are wearing watches. People are having long sleeves. People are having their things open, being closed. People are having their hairs over the thing. They even go outside the hospital with it. So you see, so this is extremely important. Keep up hospital hygiene, because you are transmitting the microorganism from one patient to the other. This is in our hospital enforced. So we are not allowed this. If they see that, you say, go, you should take it out. We have to have this, and it's enforced by the head of the department, enforced by the hospital infection prevention control committee, enforced by the board from the hospital. These are the procedures. Of course, hand washing. You know, it's all important. What we have to do: wash your hands before you see a patient. Wash your hands after the patient. When you buy a chicken, or when you eat chicken, maybe you do not realize, but this is how you get your chicken these days. Also here in Rwanda, you have large chicken farms. You know that these chickens are fed antibiotics every day to make them grow better? So what if there's a salmonella there in this chicken? You eat that salmonella also. So animal production, so this is the Netherlands, they cut it by 80%. It's not allowed anymore, so you cannot give it as a preventive thing, antibiotics to animals. It's something very much to look into, I think also in this country. You think, so rapid diagnostics. You know, it is extremely difficult in the situations where you're working, because the patient presents and he can have a bacterial infection, he can have a viral infection. There are so many different causes for fever. So, what is the cause of fever in a particular patient? How do you know? How do you find out? So there's more and more emphasis on diagnostics. Well, if you do culture and sensitivity, you know it takes 72 hours at least. So that's late. If you do serology, same. Sometimes you have to have samples separated by 1 week. It's too late. So you actually need fast diagnostics and also point of care diagnostics. So there's been a very nice paper in Lancet Global Health, point of care, CRP testing to reduce inappropriate use of antibiotics is a study done in Vietnam. And that study used clinical outcome measurements. So they looked whether people had excess morbidity or mortality, etc. And of course, they also looked at antibiotic consumption. And the CRP test turned out to be very favorable and also cost effective, because you prescribe less antibiotics and you have to pay for antibiotics. So you can also reserve your resources for testing. So the diagnostics important think about point-of-care CRP testing. Then there were 3 more things. That was human capital, and this has been a workshop we organized because in the Netherlands we are doing not so bad regarding antibiotic resistance formation. So we have courses and we invite people actually from all over the world. People come to our institution to get a training course on antimicrobial resistance formation. And this is the group which got most attention. Is the group from Rwanda. Dr. Willy was there and Dr. Marcelin was there. And they were really very excellent. I think they got a training for a whole week. And maybe they can implement these things they have been learning also here. I think it's very important to invest in human capital. New drugs, somebody said. We are getting new drugs. I'm sorry to disappoint you, you will not get new drugs. No. And if there are new drugs, they will be unaffordable. They will be unaffordable. There is no pharmaceutical company interested in developing a new antibiotic. Why? Because an antibiotic, you take it for 1 week. And if they take a new drug for depression or cholesterol, you take it for the rest of your life. So, pharmaceutical company point of view. Or they made it extremely expensive. We have seen one new drug, it cost us a fortune. We once treated the patient, we spent 350,000 euro on 1 course of antibiotics. This is, so forget about the new drugs. So the last slide is the conclusion. Antimicrobial resistance is a serious threat for global health. Urgent actions need to be taken by policymakers. Many things in the Netherlands, they are by law. If I, as a healthcare worker, do not want to comply with it, I'm fired. I'm just get out of the hospital. So it's enforced by law. We have to rationalize our antimicrobial prescription. Do not count on new drugs and hope for good diagnostics. I think this is my last message. Thank you very much.
My name is Dr. Damas Kabakambira. I'm one of the organizers. And the next sessions are now going to consist in panel discussions. We have 2 panel discussions today, one in the morning, another one in the afternoon. So I would like to invite the first panel discussion chair, Dr. Immaculate Kambutse, one of the young, enthusiastic physicians the country is fortunate to have, who is currently working at King Faisal Hospital as a junior consultant. Would you please step forward and take the stage? Yeah, please welcome her warmly. Apart from being a physician, she's also supporting medical education and research in various capacities. She supports Rwanda College of Physicians a lot, but she's also the chair of research and training committee in the Rwanda Medical Association. And she is interested in research and does several publications. She is going to have 5 people on her panel today, but we also have an extended panel, including the president of Rwanda College of Physicians, Professor Bavuma Charlotte. We have FDA still represented, Mr. Jose Eduardo Munyanga is still around, and all of you. We will have a chance to ask questions to the panel of experts we have. So may I ask Sister Dr. Murekatete Beata to step forward and take a seat. Dr. Andre Musemakweri, Mr. Frederick Lukwago, pharmacist Maurice Ndekwe, and Professor Andre van der Ven. So they will be on the panel here, but on the extended panel, we also have the people I just mentioned.
We just had a brief presentation of our esteemed guest, Prof. Andre. Close to me is Dr. Marie Beata Murekatete. Dr. Marie Beata, she's doctor, specialist in internal medicine. She obtained her master's degree in internal medicine and a medical degree in general medicine from the National University of Rwanda, Faculty of Medicine. And since 2015 until today, she's a consultant doctor in internal medicine at Bushenje Provincial Hospital and head of departments since then. Prior to working in Bushenje Hospital, Dr. Marie Beata worked as a medical director of Kabgai Hospital, as well as initially a medical officer in the same hospital, and also Gakoma District Hospital. She's exceptionally experienced and compassionate in caring for the rural population and more interested in hepatitis and diabetes care. She's more dedicated in mentorship of healthcare professionals in district hospitals and in the management of hepatitis and non-communicable diseases. Next to her is Mr. Frederick Rukwago. He's a medical laboratory scientist, currently working at King Faisal Hospital, where he's the laboratory manager, one of the tertiary hospitals in Kigali, in Rwanda. Next to Mr. Lukwago is Dr. Musemakweli and Andre. He obtained his M.Med degree in internal medicine and infectious disease from the University of Dakar in Senegal. He's a senior lecturer in the Faculty of Medicine at the University of Rwanda, and he has experience of more than 3 decades in internal medicine and infectiology. For more than 10 years, he occupied successively top leadership positions in teaching institutions as the Vice Dean of the Faculty of Medicine, Medical Director of Butare University Teaching Hospital, and Director General of the same University Teaching Hospital. He has been deeply involved in the fight against HIV and AIDS in the community as well as in higher education institutions, where he successfully occupied positions as the chairperson of Provincial AIDS Commission. He was once commissioner of the National AIDS Commission and chairperson of the University League of AIDS Control at National University of Rwanda. For 6 years, he was also appointed by the African Association of Universities as coordinator of Central Africa University Network for HIV. Last but not least, he's actively associated in the publication in international journals for more than 10 articles focusing mainly on infectious diseases as well as parasitic infections. Next is pharmacist Maurice Ndekwe. He's a chief pharmacist at Vine Pharmacy in Kigali, Rwanda, a community pharmacy that champions the provision of quality pharmaceutical care services and products. As team lead at Vine, he's honored to contribute, along other healthcare providers in Rwanda, towards people living healthier lives. I welcome you all today. So today's panel discussion, my first question goes to you, Dr. Beata. Having worked in a provincial hospital in Rwanda, I know you're faced by many challenges, but also create many solutions in caring for your patients. So I want you to kindly share with us your experience working in a provincial hospital in terms of what has been your experience dealing with challenges and how you overcome these challenges in regards to antibiotic resistance and stewardship.
Thank you, Dr. Immaculate. As you know, I'm from Bushenje Hospital, which is near Congo. So the main language you use is the French and the Swahili. It's why I want to speak in French. Even with Swahili and the Amashi also, I know. Donc, en ce qui concerne la résistance aux antibiotiques, dans les hôpitaux de district, ou bien les hôpitaux se trouvent au niveau rural, et nous rencontrons pas mal de problèmes pour choisir les antibiotiques à utiliser. Le premier problème que nous rencontrons, c'est notre population, qui consiste en retard les formations sanitaires. Normalement, il commence par les praticiens. Quand il n'y a pas d'amélioration, il peut consulter à ce moment-là les centres de santé dans un état souvent critique. Les centres de santé aussi peuvent traîner de transférer les patients au niveau des hôpitaux de district. Arrivé là dans un état critique, on ne fait que commencer les antibiotiques car on n'a pas d'autres moyens de faire des investigations. Là-bas, au niveau de centre de santé, au niveau de district, les patients reçoivent les antibiotiques. Souvent, ces antibiotiques sont prescrits quelquefois irrationnellement, car il n'y a pas de moyen de faire les investigations. Comme vous reconnaissez, les antibiotiques les plus utilisés à ce niveau-là, ce sont des pénicillines. Amoxicilline, vous connaissez la chanson en pigeontant. On utilise les ciprofloxacin, on utilise les Bactrim, quelquefois augmentés. Et quand on voit qu'il n'y a pas d'amélioration, on transfère les patients chez un spécialiste. Arrivé là, un spécialiste n'a pas de choix. On commence que les antibiotiques à large spectre. Et par exemple, les céfotaxime et céfotriaxone, quelquefois les macrolides comme érythromycine, azithromycine, clarithromycine, etc. Après avoir fait recours aux différents antibiotiques, on transfère les patients dans les niveaux, bon, si je peux dire, dans les niveaux élevés, comme le CHU ou Kanombe ou Tindifaiso Hospital, pour plus d'investigation, comme scanner ou bien MRI, quelquefois faire des cultures ou pour la meilleure prise en charge. Donc, faute de moyens, nous traitons les patients sur base clinique, examens physiques, quelques examens complémentaires comme NFS, ou bien CRP et CBI, les frottis, et analyse des liquides biologiques, et comme acide ou bien des épanchements pleuraires. Je pense qu'à tous les hôpitaux, tous ces examens, on peut les faire parce que je pense que c'est parmi les paquets minimum autorisés à ce niveau-là. Autre grand problème, c'est que beaucoup d'hôpitaux ne peuvent pas faire des cultures ou bien les antibiogrammes pour savoir quel germe à traiter. À ce niveau-là, donc au niveau des hôpitaux, se trouve au niveau rural, nous rencontrons aussi les difficultés au choix des antibiotiques pour traiter les patients. Dû aux normes des hôpitaux, à ce qui concerne les médicaments essentiels autorisés à chaque niveau du système de santé. Pour cela, nous sommes obligés de prescrire les médicaments disponibles à l'hôpital. Et nos populations ne sont pas capables de s'acheter des médicaments ailleurs. Par conséquent, les médecins prescrivent les mêmes antibiotiques, ce qui va contribuer à la création de la résistance. Dans un hôpital où il y a des médecins spécialistes, ils ont un autre problème approprié. Un hôpital appelé district, appelé aussi provincial, il y a des médecins généralistes, il y a aussi des médecins spécialistes. Le patient pour arriver chez un spécialiste, il doit être suivi par un médecin généraliste au moins pendant deux semaines, selon le règlement domiciliaire de santé. Donc, ce qui fait que souvent un patient arrive chez un spécialiste dans un état critique. De ce fait, le choix, c'est l'utilisation d'un antibiotique à large spectre. Vu que le patient arrive chez un spécialiste dans un état critique, on n'a pas assez de temps pour faire des investigations. On commence directement ces antibiotiques. Tout cela va contribuer à la création de la résistance aux antibiotiques dans notre pays. Bon, il y a aussi quelques hôpitaux qui ont des moyens de faire des cultures. Par exemple, chez nous, à Dihung, nous avons la machine, nous avons réactif, on peut faire la culture. Pour moi, si un patient arrive et que je donne les antibiotiques et que je fais cours à tous les antibiotiques que j'ai mis aérobie ou anaérobie sans succès, j'arrête tous ces antibiotiques pour au moins 5 à 7 jours et après, j'envoie un échantillon à Dihung pour faire culture et antibiogramme. S'il n'y a pas d'amélioration, à ce moment-là, on transfère le patient à d'autres niveaux CHU pour meilleure prise en charge ou pour plus d'investigation. Pour conclure, je dirais que les hôpitaux se trouvent au niveau rural. Nous avons pas mal de problèmes au choix des antibiotiques et nous utilisons souvent ces antibiotiques et ce qui va aussi créer ces résistances. C'est à vous, je dirais, de nous aider ou bien de nous donner un conseil comment faire pour éviter cette création de la résistance. Merci.
Okay. Thank you very much, Dr. Beata. Just to summarize for I know most of us understood what she said, but for those who couldn't understand, in summary, she talked about the challenges she faces in her daily practice in the provincial hospital. Briefly, it all comes down to limited resources, limited resources with limited diagnostic tools, limited medications, but also practices from behaviors actually from healthcare providers as well as patients, where most of them consult late and also come after consuming so many antibiotics. And by the time they arrive at our hospital, the same trend continues, which she thinks also contributes to the rise in antimicrobial resistance. Briefly, my next question goes to Dr. Msemakweli. We are privileged to have you because you have vast experience working in public hospital and eventually transitioning to private practice. From previous presentations, we've seen that it's actually a global threat, antimicrobial resistance. And we've seen that so many patients end up dying, losing their lives just because they can't get antibiotics to treat their ongoing infections. So what is your comment on how antibiotics are being used out there in private hospitals? Is it different from what is being done in the public practice, and how can we deal with this issue?
Thank you very much. I think speaking on behalf of private hospital clinics is very difficult for me because there are various situations. I never visited some of them, but I have experience of some private clinics and hospitals that I was used to go there, and I am working currently as part-time in one specialized hospital and one polyclinic here in town. So really, it is a privilege for me to talk about after Professor Andre, because he did a good overview of the problematic of antimicrobial resistance. So, and for the private here, also Dr. Beata has give a picture of his ongoing on different hospitals in the country. So the situation with the private is a bit different, because there are some good hospitals with good level of management of infections, and others are still low. But commonly, the rate of antimicrobial resistance is very high, as Dr. Andre said, because it increased the morbidity, increased the mortality of patients, and also it is very costly. That is the global challenge. The current challenge to the rational use of antibiotic in the private is one, the success obligation in the private. Success obligation, and also the concurrence and competition at this level. Because no one private can't accept that his patient fail in his hospital and go to another hospital. That is the big challenge, and they have to do miracles, between brackets. That is the problematic. You can't say to a patient, you are critical ill, you have this disease, but you have to do first analysis, and you do, for example, urine analysis, and you have to wait for 3-4 days. So that's the problem. I see also some patients who are critical ill, and the doctor did all investigations and don't find nothing, and say, I can't treat you because we don't find nothing. That is another issue. So obligation from the patient, obligation from the inherent situation that we have to be the best. That is. So the second challenge is the resistance to antimicrobial, which are known. We know, for example, urinary tract infections with E. coli mainly are multi-drug resistant. We have at around 65% of E. coli in our country are resistant to main antibiotics, including quinolone, etc. Gonorrhea. Gonorrhea is another challenge in our routine consultation every day. If we have gonorrhea, you can't say it will be okay. But we have to start by the simple antibiotic and doing go to the laboratory, and you have to rely only on the direct examination. Gram-negative bacilli, should be equivalent to gonorrhea. And you start treatment, because you can't let go the patient and waiting for 4 or 5 days. That is. The third one is the TB. TB is another challenging infection, which is now with multi-drug resistance. And the last one, and not the least, Staphylococcus aureus. MRSA, Staphylococcus are challenging us, and the burden is every day big today. As the publications done in the country had shown many things. There are many publications. You can go to internet and look for last publications on United infection, on Staphylococcus aureus, and you can get the results. So after those challenges, I think we need stewardship to address the following issues. One, as Professor Andrew said, rational use of antibiotics. Second, avoid nosocomial infections. Nosocomial infections are the main problem to bring multi-drug resistance. Meaning, nosocomial infection need hygiene, as he told us. Need washing hand. Infection control policy, education. Use glove, use disinfection, and clean the hospital. So, those are the requirements. And now, I end by the achievement in positive issues to be very optimist. The experience I have from private is some hospitals are very good and link with the requirement in terms of infection control policy and procedures. And for OPD patients, people in those hospitals, those clinics, they have facilities for washing our hands. They have gloves for examination of the patient. They have roll for consultation table, and after each patient, this roll, which is disposable, is removed. Another patient come, etc., etc., and between patients, you clean your hands, you put gloves for some examination. Though I think it is achieved for some hospitals, and the problem perhaps should be in OT, operating theaters, and some private regularly do sampling in the OT and culture for looking after microbes. And to be sure that the sterility is okay at in the operating theater. So for hospitalization, I can say it's okay. So conclusion and perspective. I think in public institutions, they are associated with the accreditation process. But in the private, it is not yet, I think. So some hospitals that I know had already started to draft all policies and procedures, and to make them signed and agreed by administration, but others nothing. Second, they have to provide the laboratory. Some private, they don't do culture. So they have to comply. And the third thing, some facilities, like in the public institutions, the TV program is there and well functioning. In the private, not yet. So some have just drugs, but it is not enough. HIV program is absent in the private. 3, hepatitis B and C, null, except to do screening. But screening is not enough. So, availability of regular monitoring for antimicrobial resistance is not done in private. I don't know the situation now in the public, but at the national level, I hope that the plan is really practical and shows how long or how much people access the current situation of Staphylococcus aureus, the current situation of gonorrhea, the current situation of E. coli, and the current situation of ICU with different microorganisms. Those are really the requirement for at least at the national level, and second to the public institutions, and why not bring those facilities to our private institutions. Thank you very much.
Thank you very much, Dr. Msemakweli. A round of applause to him. I think he's expressed different challenges faced in private practice, but although we cannot solve all the problems today, but at least it sets a pace of what we should be doing and what should be worked on. So, Mr. Lukwago, both Dr. Beata and Dr. Msemakweli have shown us different challenges they go through every single day in their practice. So, working as a laboratory scientist, I'm sure you have seen so many things going on with so many germs becoming resistant to commonly used antibiotics. And also from studies that have been done in different hospitals, university teaching hospitals, King Faisal Hospital where you're currently working, it's shown that we are having a rise in drug-resistant germs and strains. So I have two questions for you, and briefly in around 5 minutes, could you share with us the current trends in antimicrobial, in antibiotic-resistant germs that you see in your daily practice? And the second question is, what is the current status of, in terms of capability for the laboratory to be able to diagnose these things and maybe lead treatment decisions?
Okay, thank you so much, Dr. Immaculate. For the first question, the current trends of antibiotic resistance, I will share the results from King Faisal Hospital for last year, 2019. I picked out the major germs that we found are stubborn, and maybe share briefly the patterns that we have, maybe to inform even the rest of the congregation. Taking an example of Acinetobacter at King Faisal in 2019, from the antibiotic resistance tests we did, we realized Acinetobacter infection are only sensitive to around 3 antibiotics for now. The rest have almost become resistant 100%. Those 3 are polymyxin B, which is still 100% sensitive, colistin at 97% sensitive, and amikacin at 63% sensitive. The rest are 20% sensitive, 10, there are even those that are 0. So you can see, like for Acinetobacter infections, we are almost left with only 2 antibiotics. So we keep asking ourselves, what will happen if even those 2 become resistant? You'll find patients will be dying in the hands of physicians because they don't have any alternative. So that shows how big the burden is. The other example is Pseudomonas. In the last quarter of 2019, we realized there was an increase in Pseudomonas infections at King Faisal Hospital. But more alarming was that most of the strains most of the other isolates had become resistant to common antibiotics that were used, and we realized we were left with only, I think, 4 alternatives. Polymyxin B, 100%, colistin at 100%, then tazobactam, piperacillin at 83%, and cifepim at 74%. The rest are below 50% sensitivity. So you can see how big the burden is in terms of antibiotic resistance. So, and we realized 90% of these isolates, mostly Acinato and Pseudomonas, were from inpatients. So that kept us asking, are these nosocomial infections most likely? Because we also need to, that would prompt us to look at our infection prevention and control within the hospital setting. Because you find most of these very stubborn germs, in most cases, you find they are nosocomial, they are hospital acquired, and you find someone comes without that germ, contracts it from the hospital, and it becomes stubborn to treat. So, meaning the hospitals should also look at their IPC. The second question about the capability of labs to do diagnosis and other complementary tests. For the case of King Faisal Hospital, we are able to do cultures, that different cultures, from blood culture, swabs, urine cultures, and then do the antibiotic sensitivity. Only that we usually have disruptions of supplies, like for blood cultures, there are times when we have shortages, we have stock out. So it's a nationwide problem, and it's mostly based on the volumes of the volumes that we consume. You find most suppliers are not so much interested in supplying certain commodities just because the consumption is too low, meaning at the end of the day they don't basically benefit reasonably. But we keep insisting, and we would request regulators to support so that we ensure that we have the supplies that are necessary for such tests. We are also able to do CRP, as he had said, which can be used to rationalize the use of antibiotics. And of recent, we also introduced procalcitonin, which is a very useful marker to decide whether someone has a bacterial infection or a viral infection that you rule out or rule in. And even after giving antibiotics, you can still do the procalcitonin to monitor the response. If procalcitonin drops, then you're sure you're doing a good job, your antibiotics are working. And if it doesn't, then you have to think of something else. So I think, thank you so much.
Thank you. That brings me to the subset of my question. Like, mostly we see patients coming in, especially those coming in through emergency department, like hospitalized patients, presenting with acute febrile illness. The first instinct, they're still at casualty, is to draw samples and immediately start antibiotics, while actually maybe it's just a viral infection, fungal infection, or maybe a drug reaction. So are we able to still do cultures for these fungal infections, test for viral infections as well? And if so, is it also done in other parts of the...
Starting with viral infections, currently, I think it's the National Reference Lab that is fully equipped to do viral infection testing, because they have different facilities of they can use, like PCR and other tests that they can do. But for routine hospital work, I think it's not really something common. For fungal infections, at King Faisal, we have the capacity of doing fungal cultures, but there's also a test that we usually do, is BD glycan, which can help us know, which can help the clinician determine whether the patient has fungal infection, or still help them to rule in and rule out. So since the fungal cultures usually take too long, between 4 to 8 weeks, the best alternative would be doing that BD glycan, which can easily give you a quick result, maybe a day, not more than 24 hours. You can either decide whether this patient has a fungal infection or not. However much it doesn't rule out going further to do the culture, which will come later in the time.
Thank you very much, Lukwago. We all see that there's still a long way to go. Although some hospitals have some of these tests done, but some of our hospitals have actually struggled to do blood cultures at the minimum. So there's still a long way to go, and hopefully in the near future we'll keep on improving. So my other question goes to Maurice. I want to ask you about a comment on the dispensing of over-the-counter antibiotics. So as Prof mentioned, a person with a common cold just decides to come, or a sore throat, and they end up getting a cocktail of antibiotics, mostly over the counter. So do you think this exists? And if yes, what do you think is the role of community pharmacies in protecting our arsenal of antibiotics?
Well, thank you very much. You can see here we have somebody from a district hospital or referral hospital in lab, and then a very experienced person in infectious diseases, Dr. Musemakweli, and then Professor here, and me, somebody from the community pharmacy. Like eight or even 10 years ago, you would walk into a pharmacy and you would not find a pharmacist. Very few had pharmacists. You'd get a nurse, but because at that time, the university was producing very few pharmacists. Today, when you walk into a pharmacy, it's not just because of the regulation, but you'll find there are 2 pharmacists at least, in each shift that a pharmacy has. And that is a response that, one, there's a demand from the public that we are serving, that we provide better quality. But there is also an internal realization that the better the quality of the professionals we have, the better the service that is delivered to the public. Well, I've had an opportunity to actually to face the same encounter that Professor talked about, where a patient comes and they tell you, I want an antibiotic, and they specify. They tell you, this is what I want. And so the traditional practice 10 years ago, a nurse, probably because at that time they would just give an antibiotic, amoxicillin or what, and they prescribe and the person goes. Today, with a better workforce that is trained, when you come to a pharmacy like ours, I'll speak for ours, we will ask you, we'll do a triage and find out, just a simple questions we'll ask you. And they will lead to us to know whether we have to just give you the normal symptomatic treatment of paracetamol, antihistamines, and or probably even advise you to take lots of fluids or even rest, as the doctor said. We will even advise you to go and see a doctor. I know it's if you're a business person, you're selling medicine, you're also treating, you're giving a service. If you look at it short term, for a person who is doing business and is a pharmacist, short term, they will sell the drugs. They'll probably even. But if you're looking at it long term, you will recommend, the first priority is to recommend the person to go and see a doctor, get proper tests and get to verify whether they really need the medicine or not, or that's the right medicine that they need, or they need any other solution beyond that. So the other shift we've seen in the past years is that everybody wants to play doctor, even the patients. We are seeing people, there's a lot of information on internet, and people will come and tell you, no, this is the way I feel, and this is the right thing for me. And you're in a pushback, this is somebody who has come to you, and they trust you, because you've developed a relationship with them. That's the pharmacy they use day to day. They get the best advice, and they've relied on the advice, and it has worked for them. So how do you deny them a shorter way of, faster way of getting treatment than going to queue at the doctor's clinic? So it's that kind of push. So we do a triage, and mostly we prefer to recommend that the patients go and see the doctor. And where the patients have actually listened to us, they actually come back to us. Some pharmacists may think that, if you refer the patient, they may just walk to the next pharmacy and get the solution. Yes, behaviorally, some patients do that, but most cases for the people who really trust us, they follow our recommendation, they go to the doctor, and then they come back and they say, your advice was the best. They found out I don't have this, actually I have this and this and this and this. That's the way we're handling. Yeah.
May I add something here, please? My aspect. The private patients become less today because many people have health insurance and they come with a prescription. So those people just go to the pharmacy to buy antibiotics, very, very few. In my routine consultation, it is around 20% of the patients who are private, 20%, even less. So don't worry.
Thank you very much. So I will give the privilege to someone from the room to ask a question to Prof. Andre, whichever question you want. And within the next 20 minutes, we can at least take 3 questions addressed to any member of the panel, including Prof. Andre. And we'll start by briefly introducing ourselves and mentioning the name of the panelist you're addressing your question to.
My name is Abumurimi Ale, a junior consultant. My question goes to Dr. Andre Musemakweli. I want to give my own experience. I have my son who's known with hyperactive lung disease. I brought him to the private clinic with fever. They did all the investigation. They found no problem. All were negative. And the doctor prescribed anti-malaria, amoxiclav, nystatin, steroid. And he told me that I think this can help your son. My concern is now, it's wrong, or we can keep, because probably it was a viral infection, but he give all, yes. My question is the prescription. After all the investigation, and because all the investigation were negative, and the doctor prescribed anti-malaria drugs in the same times with antibiotics, antifungal, and the steroid in the same time.
Unfortunately, that is a common situation in public, in private institutions, because they should treat, even if they don't find nothing, because the child was febrile, and the diagnosis was Nothing. There is another diagnosis which is very current. No. Infection, il y a marasso. Vous faites infection, marasso. Blood infection. Blood infection is the most common diagnosis. People come in consultation, they got fever, and they treat me like infection in the blood. What that means? Sepsis or what? Huh? Infection in the blood is CRP is positive. Or sediometry. Huh? Or Vidar positive. Those are really a problem of guidelines, a problem of awareness, problem of training that Professor Andres said. So we need to train even in private practice because the situation is there. So if someone doesn't understand nothing, he refer, not keep the patient. Never accept that people do like that. Go away and look for better investigations. Because in private and public, there are a lot of tools to make good diagnosis. And my colleagues said that they do a lot of things. Thank you.
Thank you very much, Immaculate. We are laughing, but I think this is a forum which should guide stakeholders, because we are really killing our population by misusing antibiotics and other antimicrobial agents. I think from here we have to make a recommendation and submit it to the Ministry of Health. I think the concern is not to find diagnosis, but we just want to show that we are doing something. And we have the right to tell the patient, I don't have diagnosis. We have to keep searching. So I think we have to be honest and then communicate with the patient. We have to make a strong recommendation from here.
Thank you very much, Prof.
Thank you for the panel, for the discussion. You gave us an opportunity to ask the visitor a question no one so far has done, so I'm going to do so. The place I trained, there was a hospital committee for antibiotics, and there was a restriction in terms of the level of the doctor and the kind of antibiotic he or she could prescribe. Nowadays, we have got something similar that, for reasons that are unclear, came from the financial side. It is the insurance that started putting restriction on some doctors, saying these you can prescribe, these you cannot. Such things should have come internally from a discussion like this and focused on where the biggest problem is, which is not financial directly, which is rather worsening our chance and making sure in the next 10, 20 years we do not have anything else anymore to give, which is what you introduced. So do you think such regulations, putting in place a system that decides who can prescribe these, who cannot prescribe these, at which level, and having things coming back under control of a body could work in this country? Rwanda, as you've seen, we cannot claim we are the most adherent people to everything. We have our own problems, but usually when something is given in this country as a direction, it is followed. What we experience with other countries, do you think it can work in our setting here? Thank you.
I can tell you how it works in the Netherlands by law. By law, every hospital needs to have a stewardship team. And that means that if somebody prescribes an antibiotic, that is because we have an electronic system, that every day we have a small committee which comes together. That's a microbiologist, a pharmacist, an infectious disease specialist, and they look what is being prescribed. So what is the indication? What is the drug given? And if the dosage is correct, etc., etc. So only certain doctors can prescribe certain kind of medication. Like say, if you want to prescribe meropenem, the same day or even within an hour, somebody will come to you and says, sorry, you are prescribing meropenem, but you cannot prescribe it. It's only that special committee which can prescribe meropenem. So what is the problem with this patient? And so that's how we recommend. So secondly is then, it's not only the indication and the drug which is given, but also the duration of treatment. So when somebody's, so we know exactly that person is on, let's say, penicillin for a pneumococcal infection. The patient is having no fever for 72 hours. Somebody will come and say, stop the antibiotic. There's no reason to continue it. Or somebody's going on with IV medication where you can switch to oral medication. It will be directed from above. So point one, we have indeed for every hospital, by law, all the hospital has to comply. They have a stewardship team, and all the antibiotics there are more or less controlled. And secondly is not all the doctors can prescribe all the medication. Some are restricted to certain infectious disease doctors, they can prescribe. But for instance, if you have a surgeon, he cannot prescribe any antibiotic. So we have strict regulations. You can only have such system when it comes from above. You know, the place where I work is in Nijmegen. It's about 10 kilometers from the German border. So we have a university hospital of around 600 beds. And on the other side, there's also a university hospital from a large town. In the Netherlands, the infectious disease specialist can say to the surgeon, you are not allowed to give that medication, so you have to stop it and switch to that one. If in Germany, the infectious disease doctors goes to the surgeon and says, listen, why are you giving? Then the surgeon says, what are you doing here? Just go away. I just do whatever I want. So it requires regulations, and it requires leadership. And without leadership and regulations, doctors will do whatever they feel like doing. And they say, well, I feel this patient is very sick, and I feel he needs maybe an antibiotic and an antifungal, and I don't know. He feels, yeah. And there's no arguments against that. So you have to regulate it, otherwise it will be very difficult.
This patient in front of you has got a very big impact on the community. We should be very disciplined. In fact, in some hospital where I was working, we had actually a senior physician, but he was very undisciplined. His use of antibiotics, it was actually data use of antibiotics. I hope maybe with time he's going to change, or maybe he has changed. But we should be disciplined the way we use antibiotics. But we should be regulated by, again, coming back to civilized way of practice, we should also be guided by culture and sensitivity. Because when I was young, so many years ago, when I was learning microbiology, we were saying whatever you do should be guided by culture and sensitivity. And when you are starting the empirical treatment that you are using, I hope it is still the same teaching, the empirical treatment, you should also inform the laboratory scientist. You will start this antibiotic so that you get a feedback that this antibiotic you are using has worked. But we've got a situation here, in this country particularly, where you can have culture and sensitivity done, it is in very few hospitals. She has mentioned it, Dr. Beata has mentioned it. And at the same time, I think we should go out and advocate for more resources. Advocate for more resources. I am glad we have the FDA. They are here. I think we should, as a way forward, actually, we should partner with FDA, assist them, and in fact, partner with other associations, particularly the surgeons. I'm glad in other countries there is a mechanism to restrict what the surgeons are doing, so that the others, obs and gyn and whatever. In fact, sometime we should have a similar symposium on this matter across the board, maybe for all the specialties, so that at the end of it, we can make recommendations that to translate into legislation. Thank you very much.
Thank you very much.
Thank you so much. I'm Dr. Lizine. I'm a pediatrician. I'm the chair of Rwanda Pediatric Association. So I'm invited in this forum. Thank you for the invitation. I'm so happy that we're talking about this subject because it's a big issue for pediatrics, starting by neonatology and also in the community. You know that our community health workers are prescribing amoxicillin easily. So this is very, very crucial in pediatrics. But my question is going to the pharmacist. So some years ago, there was laws and regulations for prescription of antibiotics or buying antibiotics in pharmacy. They used to have a prescription automatically. But now it's like no limitation. So what is happening today? Because at that time we had a Minister of Health who was a pharmacist, and it was working very well. So can you come back to those rules and regulations and see what we can do for those issues? Thank you.
Last point goes to Professor. It has been said if we withdraw an antibiotics for a given time, then maybe the antibiotics is going to work. I was asking for maybe thinking of the future generation, if some antibiotics may be withdrawn to the market and with very restrictive use would maybe help.
Yeah. So it actually, that's what we know from malaria. Eh? So when you don't lose chloroquine for a long time because of resistance, after some time the malaria parasite becomes sensitive to chloroquine again. So that, and that's of course also the very much likely that if you withdraw, stop using beta-lactams, I mean the sensitivity for beta-lactams will come back. Yes, it's all related to exposure. So microorganisms exposed to certain drugs, they will develop resistance. Maybe I can also take a last opportunity because, as I said, I worked in Botswana for 6 years, and I worked there before there was any HIV. So it was in the 70s of the previous century. There was no HIV. Yeah, it sounds horrible, but anyway. So, but then the hospital, I don't know how it is here in Rwanda, but in the Netherlands, hospitals are run by nurses. Huh? So if the nurses are crucial in a hospital. So if you don't stick to IPC, the nurses will tell you, listen, you cannot do that. In Botswana it was the same. So there were strict regulations and they were very well maintained on hospital hygiene. But then, I've seen it, then the HIV epidemic came. And then massive overflow in this hospital with all these patients with infectious diseases. And then everybody had infectious diseases. So it looks like everybody forgot about hospital infections, so all the preventive measurements, because they was just overwhelmed with all these infectious diseases. But now you have the ARTs and you can control your HIV. I think it's time to go back to the old days, and maybe the old nurses know that you go back to hospital hygiene, and then the nurses again take being in charge for running the hospital and taking care of the hospital hygiene. I think that's a very simple, maybe a measurement which is not so difficult to take.
Thank you, Dr. Lizine. Somebody from the FDA is here, and he's listening and he's watching to what I'm saying. Well, the law is still there, and actually now we are better prepared to actually enforce the law. What we would probably do from our side is that we'll raise awareness within our pharmacy community. as in within the Association of Pharmacists, and I think even the FDA here is going to push that is enforced through our network. And it's true we are doing that. Probably there are some loopholes, yes, but we will enforce. Yeah. Thank you.
Thank you very much. I'd like to thank very much all the panelists and everyone in this room for the interactive discussion we've had. And as we return back to our seats, I would like to give the floor back to Dr. Kabakambira to tell us what's happening next.
Thank you. Thank you very much, Dr. Kambutse Immaculate and your team. Thank you so much. We appreciate it. We can give you another hand of applause. Thank you everyone for coming. We have come to the conclusion of the morning sessions. We've had presentations from various infectious disease as a kickoff in the morning. Then we went to malaria, and then we just spoke about antimicrobial resistance. We were fortunate to have local and international experts. And you need to stay tuned. In the afternoon, we are going to talk about outbreaks before we dive into the several decade pandemic HIV. So you still need to wait for the ice on cake. You've had the cake so far, but what is pending is even more important. So we are going to go for lunch from till 2:30, and then 2:30 we need to be in the room here so that we start with the first presentation by Dr. Emmanuel Musabeyezu. He will be speaking on Lui pour vous. He has gone through literature for us about the current outbreak. Thank you. Enjoy your meal.
This symposium has been organized to update physicians and other health professionals about malaria and HIV management and antimicrobial resistance and rational use of antibiotics. We wanted to raise the awareness of physicians about how they have to prevent antimicrobial resistance and to use rationally the antibiotics. So there have been exchanges between stakeholders and prescribers and pharmacists about the rational use of antibiotics. We have shared the experiences from clinicians, and we come up with the conclusion that this is national and global challenges, antimicrobial resistance. So the take-home message from this symposium has been to focus on hand hygiene and to use rationally antibiotics. And we don't have to target the use of new antibiotics. Even old antibiotics are still effective, and we have to involve each and other for the choice of antibiotics to be used. And do not prescribe antibiotics for any reason without consistent clinical argument and biological argument.
One of us, a physician, who is going to brief us about coronavirus, which is a new infection we have to deal with. There is no way RCP can just sit and cross the arms, so we need to participate. And I am going to call upon one of the senior physicians we have in the country, so that he tells us about this virus. And then afterwards, we'll have an expert from the Rwanda Biomedical Center who is going to tell us the preparedness at the country level. So I'm very privileged to invite Dr. Emmanuel Musabeyezu, who is a physician, pulmonologist, who is currently working at Glamrec Clinic at the same time as King Faisal Hospital. He takes care of respiratory diseases, patients affected by respiratory disease. And he hasn't taken care of any patient with the coronavirus yet, because there has been no case in Rwanda, but he's very interested in new advances in medicine and infectious disease, and he has extensive experience, as all of us here in the room know. So I am very humbled to invite you, Dr. Musabeyezu, to share with us what you have about the coronavirus.
You talk about something you've seen, you've worked with, and you talk about your experience. In this case, it doesn't apply. That's why you've seen the title of my presentation is Lui pour vous. For those who do not speak French, it is Lui pour vous. For those who do not speak French, it means something I read for you. So, and the exercise is going to be about reading. And my presentation is structured around a couple of papers that has appeared in different journals about the coronavirus. That is what I'm going to go through, hoping that at the end of the presentation, we'll cover some aspects. I say some because we cannot cover all of it in the 20 minutes. I may hit the technical challenges, but I think it's going to be there to sometime link with the hyperlink to get things done. The acute viral respiratory infections account for more or less half of the infections, acute infections you treat. The report that we get in from where things are well documented in the US, it tells us that each year, each person got between 3 and 5, 6 episodes or events of acute respiratory viral infection a year. And it can go up to 8.3 cases for children. Now, in terms of time lost, it is 30 to 50% of the time lost from work for adults. And what we discussed this morning, the use of antibiotics in this case represents the major source of abuse of the drugs, as we learned this morning. Now, if we go to the coronaviruses, they represent a single-stranded RNA viruses that has its reservoir in many animals. And before this SARS, 2 groups were very known. They are indicated there. And they're contributing to 10 to 50% of common colds. And when you were to get antibodies in the population, you could, in an adult population, you could, by ELISA, see that could go up to 80%, meaning they were there, not causing trouble. But trouble came after 2002, and in 10 years later, when you got these 2. And as we're gonna see, these are diseases that are coming from the animal called zoonosis, and that affected us. I will not talk about these 2 because you read extensively about them. What I'm gonna talk is the new coronavirus 19. Now, the name they gave it was novel coronavirus. Because it is a coronavirus, it was called novel because it was new, and some then changed that. It wasn't called coronavirus 19 because this is the year they refer to, and now even people are starting to call it SARS-2. Why do they call SARS-2? Because there is the first one, and this is now a second one. So the names can be confusing, but I want to go first in that terminology to understand that I can use any of the 2 or the 3 for same thing, or whenever you're gonna be reading the paper, it will depend if it was this week and the name will change the following week because people look at it differently. Now, I'm gonna talk about the pathogenicity and transmissibility of this virus. This paper called Pathogenicity and Transmissibility of 2019 Novel Coronavirus, a quick overview of comparison with other emerging viruses, which appeared in the Journal of Microbe and Infection, which was available on 4th of February this year, takes us through a couple of things that I'd like you to look at these. Now, first, when it comes to pathogenicity, it takes us, could they reduce the light, reduce the headlights so that it comes darker so that people at the back could read? It takes us to one thing. It tells us that this coronavirus, when it was, it started in December, the quick response was that they were able to do the sequences, and what they come up with that was this. It has the 80%, 82% homogeneity with the SARS that we heard of first. And because it has 80% similarity in the gene that they were able to find, that they were expecting to see the clinical presentation be the same. About the transmissibility, there is this thing in epidemiology, they call it raw knot, which is by definition the epidemiologic definition of R naught is the average number of people who will catch a disease from one contagious person. How many people one person can contaminate? If it is less than one, it means the epidemic will go down. If it is one, it stays there. If it's more than one, that is where we're gonna go into pandemic. And from this paper, although they acknowledge that this is still it's a dynamic thing, they were evaluating to be around 3.5 to 5.5, depending on which period of you are in the epidemic. Now, the next parameter I want to show on this is the relation between viral pathogenicity and transmissibility. What is known is, if a virus is transmitted, has low pathogenicity, meaning it has to show very little clinical signs. People will not know who has got the disease. And that makes less prevention, less awareness. We will not see who is the sick person. That will increase transmissibility. If a virus is so bad that the pathogenicity is quick and severe, like Ebola, people will identify the person, isolate, and that will decrease the transmissibility. That is something that this paper talks about. And this table here, it gives you the different case fatality and the R node for different viruses. You could see that we believe it is around 3 in the coronavirus, the novel one, and this is where they put the transmissibility. You see what the SARS was, 10 case fatality, while MERS, the one that from camels in the Middle East, was around 40, very, very terrible. Yet, it was less than 1 in terms of transmissibility, and that's why it is now contained in the animals, didn't go spreading. And when you look at the Ebola, 70 as the case fatality. Transmissibility, one Ebola patient could contaminate around 3. So this is where we are with this virus, and this is a concept that as it gets more and more precise, will guide us in terms of where we're going. This one is a paper that appeared in the New England Journal of Medicine. When you have the virus, you have the case fatality, you look at which way will it evolve. Is it gonna be a pandemic? And where we are, has it been contained or not? And we're gonna put some remarks. On this one, you could see that the novel coronavirus, we don't know yet. In this paper, they didn't put a figure for the case fatality. Will it go pandemic or not? They say we don't know. And the containment efforts are ongoing. But when you look at H1N1, it did go pandemic. It was with a low case fatality rate, as we explained. It has not been not contained because of the low case fatality and going pandemic. You look at the next one, H7N9, high case fatality. It didn't go pandemic, and we are still having it in the poultry reservoir. When you look at the SARS, which we know, it went with this case fatality in the documented one in this paper is this. It did go pandemic, yet we managed to have it contained from doing effort. But what's most important about this is you look at how much nosocomial transmission is there. And that is the point I also want to make about this. This nosocomial transmission is something that we learned from SARS and MERS, which is something that is terrible if we have to look at the future. It is concerning for all of us. While Ebola, with a high case fatality, didn't go pandemic, and we can say it was contained. From this, you can infer a lot of things. Efforts put on, like Ebola, when the US Congress gave, 7 point something or 12 billion, we invested in West Africa, it was contained. But the similarity are not the same. This is a different virus when you compare both. It's unknown, but we know it's gonna be most likely low. But the capability to contain a virus depends on much of these parameters. You look at the type of evidence we need to control an epidemic. And here they look at the evidence needed and the type of studies. This is like if you were in an ideal environment dreaming. Number of cases, including milder ones, are needed to know if you have, to know the syndromic surveillance to get there. Risk factor and timing of transmission. You will need household studies. Severity and attack rate, community studies. What we call severity pyramid, to assess that, you will have to integrate many things. But this one is what I believe is maybe the one we got something. Infections, timing, and intensity, you will need to know the viral shedding studies. And I'm gonna show you one that was done to give us the idea of this issue. Are the people shedding viruses before they become symptomatic, or is it after? Are they contagious? I think it is 1 week or 2 weeks maximum old. And it tells us about trying to assess the viral load in the upper respiratory specimen of infected patients. And in this study, they monitored viral load in upper respiratory specimen obtained from 18 patients, 9 men and 9 women, with a median age of 59. And you see the range, and including 4 patients with secondary infection, one of whom never had symptoms, with 2 family history clusters. And when you look at this, the finding put as a table, it gives you something like this. This is for the nasal swab. They look at the days since the onset of the symptoms. And when you look at that, the symptoms, they are there once the viral load is somewhere high. And with time up to 21 days in the nasal swabs, it is nearly disappearing. But when you look at the throat swab, what you see, the amount of virus in the nasal swab is higher than the throat swab, assuming the technique of taking sample is the same. But the same period, about 21 days since the beginning of the symptoms, is more or less where you know that the virus shedding in the upper respiratory system is down. Now, there are, I'm not quite sure if I could put that on another slide. They tell us this receptor, angiotensin converting enzyme 2 receptor, is in the body, in our body, in the human. It is in the respiratory system and the gastrointestinal system. That's why some of the virus will be attaching there, and they will have symptoms like diarrhea and so on. Now, this is something that could guide to say, is someone without symptoms contagious? Yes, because they could see the viral load being the same in a contaminated with symptom, like in the contaminated without symptoms. That is the basis to say people without symptom can be contagious. It's in a military medical journal, and it is coming from the city where the virus was described. And what they tried is to give us a rapid guideline for the diagnosis and treatment for people infected with pneumonia. What is this guideline useful for? When you look at guidelines, you will have the World Health Organization, the CDC, many other, the NICE from the UK. These are people who are miles and miles away from the site where the problem is. That's one. 2, some of them has a public service-minded approach and a political-minded approach. I chose this one, which was written by the frontline people, the ones that are handling the epidemic. And I will leave you with Kabakambira the link so that you can look at this. It tells you what to do. Guideline methodology, the level of evidence, and how they got that evidence, and it tells you if you do this, you're gonna be knowing that this is the kind of level of evidence you are on. Let me pick somewhere in the middle on something like They show you the pictures of the city, how they are, how they present, and it's quite long, something like 23 pages. Let's give you an example. You see where we are, because the previous speaker talked about the antibiotics. They say, principle, avoid blind or inappropriate use of antibiotics drugs, especially the combination of broad-spectrum antibacterial drugs. Enhancement of bacteriological surveillance should be performed and promptly given appropriate antibacterial drugs when it occurs, when there is a secondary infection that happens. This is an example. Why am I picking on this one? Because we discussed this, and we shouldn't be thinking we're gonna give antibiotics because the patient is febrile or very sick. This idea of a patient very sick needs antibiotic, we have to leave this room leaving this idea behind. Now, next to this is the other thing that is very important, to put in perspective that this whole thing is about supportive therapy. And when you look at this, it is the equivalent to the ARDS guidelines about inflammation. And one last thing about the therapy, and maybe I had the paper, but I thought it was too much. It's about the thing that you've heard about chloroquine. You heard about it is active in vitro. I looked hard and I say, yes, they're saying it is working in vitro, but no paper has come out saying that we can use it. And I try to think, why is it the case? And for me, the disease phenomenon with the virus, it is the inflammatory phenomenon that we're seeing. Even if chloroquine was to be active in vivo, the time you get the symptoms and you give it, you may get rid of the virus, but the inflammatory cascade will continue. And this is an assumption that I have personally. It's not in any book or article. But when you're gonna see this, you have to start thinking that the equivalence of what we see in different virus, hepatitis C, you get someone, you eradicate the virus, but the fibrosis phenomenon has started, it will continue, and long after 2, 3, 4 years, you're gonna have the cirrhosis and the cancer while you've taken the virus away. I guess that is why, beside the in vitro activity of the chloroquine and the, I think remdesivir, another protease inhibitor, we didn't see anything coming out to say we have been able to use this and come out with good outcome, because the aim is not to get rid of the virus. The aim is to get rid of the symptoms and get the patient well. We know that the virus came from bats. And part of what we learned when we have an epidemic is to work on the patient, but we have to look at where is it coming from. And this study, when I was reading, I found very, very interesting that some people have looked already back to 2002, when SARS was there. What is the role about bats? What can we do about it? And the funny thing about this was this, that it is showing that they identified that a period in the life cycle of the bats when they are young, when it is a certain season, that where the poo-poo, the caca, or the of the bats is having high viral load. And if we are to ever take precaution about bats, it will be during the some season of the winter. And what was interesting about this, they were sampling swabs of fresh feces were collected from bats captured in Uganda, Rwanda, and Tanzania. And it is not very often that we can find in a newspaper something that relates to the place where we say sampling is something about always far. And they realized that when they took these, they found that the end result of this whole conclusion, you see the area where they captured the bats from, we were, in terms of sampling, quite well represented. These are entomologists who we know that are quite useful in some spaces. The conclusion is that the data found from hundreds of these that the coronavirus shedding is expected to be more frequent when pups are becoming independent from the dam, independent of the age of the bat, their species, their location, and their life history. However, they continue this. Shedding may differ by species. The result can guide the temporal mitigation strategy to prevent bat-associated coronavirus exposure using non-lethal method in limited resources settings where longitudinal surveillance is not feasible. So, we should high-risk period for coronavirus shedding when contact with the bat should be avoided. Follow the common news. They saw this gentleman, Redfield, from the CDC, who is the boss, having said that the SARS coronavirus 19 is to have a foothold in the US and it will behave like seasonal flu. Why did he come to this conclusion? Because it has a low fatality rate, high transmissibility, it will spread, and it will be coming seasonally. And this is most likely where we're heading. Now, I don't know if Sabin is already there. Is Sabin around? Not yet. This gentleman, like 4 or 5 years ago, he visited us here in Rwanda, and I remember sitting with him in the auditorium or the boardroom at King Faisal. I think, Constance, you were there when Redfield visited us. We were discussing about hepatitis, and yes, from the University of Maryland. You remember that? We showed him patients. We didn't have a solution for this, and he was telling us, don't worry, in the next couple of years, hepatitis will be treated like malaria. We have treatment for it. Today, you know, all of you, that I do not see any more cases of hepatitis. You treat them at the district hospital. So he told me once something, I see it happening, I guess this is right, and that is the direction we are heading into. And I think you cannot find a better article that fits the context we are in and the topic of our symposium is this article. You know about the influenza virus pandemic of 1918. It killed 50 million people. If you were to take what 50 million people were there, it is equivalent to 200 million today in relation to the world population. And it has remained the benchmark for the worst epidemic that world has ever faced. Nothing like that has ever happened since. But what this tells us is that we go back to look at all these things that we see. Why are they happening? And this Pandora box in the Greek mythology, it was Pandora received the box that she was not supposed to ever open. But because of the human behavior and weaknesses, she opened and released the world's misfortune and plagues. Now, what does it have to do? If you look at what happens nowadays, you look at the way as humans we behave, the way we affect the environment in which we are, we have to realize that in our crowded world of 7 billion people, a combination of altered human behavior, environmental changes, inadequate global public health mechanism now easily turn obscure animal viruses into existent human threats. If I was to go down, it tells us that the human genome, it took 8 million to evolve by 1%. But many animals' RNA viruses can evolve by more than 1% in a matter of days. The previous morning presentation was talking about the mosquito behaving differently, changing the way of the time of biting and so on, and resistance. It fits in this sentence. We look at the way the battle is, because the topic of this was we are winning some battles and we are facing new challenges. And the new challenges we are facing is these. We're trying to have our brain working hard to catch, to control the viruses. Yet they are also genetically changing, and who is gonna win? That's where the challenge is. But when we look deeply into this, there is a table that, oh no, I don't think it's a table. They put it in the different words and look at the whole list of things we're facing. Try to figure out that HIV, that is gonna be the next talk. It migrates from primates. The flu influenza, the bird flu, the maize from camel, this one from bats. It is our contact with animals and the fighting for space that is bringing all these. Ebola, it's from the bats. They tell us the change in the way we do our agriculture and thing. It links with the Zika virus in South America. The whole thing is the way we behave. But what they also say in this article is, before the world became a global village, communication wasn't that much. Epidemic used to stay limited. Now our behavior, Kigali is linked to Cairo, where we've seen cases, linked to Dubai, where we've seen cases, to Belgium, to London. Couple of hours, one visitor on a plane, the virus is here. In old days, it used to be a problem. And the 1918 virus influenza, it was spread by railway and plane that were starting to become a problem. This one, it is about genetic analysis of novel coronaviruses receptors in different population. That rumors about black being having a different genetic makeup that will make us resistant. These came as from Nature research, and Nature is, as you know, it's a review that we respect. And what they tell us, because I have to jump quickly to the conclusion, in summary, they analyzed the coding region variant of this receptor, and they come to this, the last sentence. The East Asian population have much higher RFs in these variants associated with higher expression in the tissue, which may suggest different susceptibility or response to the novel coronavirus from different population under the similar conditions. So this is something to follow. No one has checked us to see how much we have and to say if that difference they observed is statistically and clinically significant to say that we are protected. So to say that you've seen a difference, you have not concluded the difference is statistically and clinically significant to make it a conclusion. That's why I still classified it under rumors. We have to hope that the vaccine gets here. We hold until the vaccine gets here, because in every other virus that we've had, vaccine has been easy to get, except for HIV, of course, and hepatitis C and a few. But if we look at the disease for which we have a vaccine, viruses constitute most of them. And there is a hope that maybe in 18 months, 24 months, we can have the vaccine, and that's what may help us. And with this, I thank you.
I saw many of my professors here when I was a student. I remember Dr. Musemakweli teaching me about tiroir. And you cannot manage epidemic without having tiroir. It is just impossible. So j'utilise le tiroir. Yeah, so thank you very much. I'm going to try to manage the time. I think this morning Deje Zuberi talked about coronaviruses and quarantine and isolation that we need every hospital to have. Dr. Emmanuel just talked about the science, the epidemiology, and everything of coronavirus. I'm just going to talk about the system. That is it, and the principles. So it's about preparedness of outbreak. case for Ebola and COVID-19 and other public health events. What we need to know, number one, when we talk about epidemics, what does it mean? It means sustainable development goals in danger. Because when you have an epidemic and you don't control it, which means your GDP will go down, everything will just stop. So ni intambara itari y'amasasu, ariko ni intambara y'icyorezo. So which means the epidemic are really linked with the sustainable development goals. And if you go to the SDG goal 3, you will see that ensure healthy lives and promote well-being for all at all ages. And if you go down on SDG 3D, you will see aim to strengthen the capacity of all countries, in particular developing countries like ours, for earlier warning, risk reduction, and the management of national and the global health risk. So when you talk about epidemics, immediately see the sustainable development goal, see the vision 2020 that is ending, and see the vision 2015. If we don't manage outbreak, we'll not reach there. So it is, again, as I say, a very complex framework under which the epidemics operates. So the goal normally it is to have a national resilient capacity and capabilities. Here is two words. When we talk capacity, what do we mean? And when we talk about capabilities, what do we mean? Capacity is like having a water tap. Robine, ukayubakira umuturage. That is capacity. Now, does the water tap provide water anytime that I need water? That is capability. I have an hospital. That's good. I have doctor. Great. Can I handle a coronavirus disease? That is capability. So it's not about having an infrastructure only, having people only. Now it is handling. What do I mean about handling? Do I have a medical doctor who will hear corona and will not run? That is capability. Yes. We see people locked, people, Ebola. After a training and the simulations, they see a case and they run. Phone off. Nimero ndishoboye kuboneka. Ongera hamagare mukanya. Wow. Yes. Muhamagare Jose Murarabisi numenya biriya bintu je simpari. Wow. Of course, this happens every day. So it is a very big framework. So it is started by the One Health, the partnership, the risk profiling, and many, many things. So you can have this national resilience for health security. This is how our system functions. We cannot have a system that is not functioning. So it starts by what we call the integrated disease surveillance and the response that we try to implement in all hospitals since 2011. And these are just the system, how it functions. How do you identify your case? If the clinical doctor sitting in the clinic understand that cholera is one of the diseases under surveillance, how do you report the cholera? How do you write it in the register? Do you write, instead of writing measles, you write skin infection? What is the difference between skin infection and the measles? That is it. So it's a lot. And we as medical doctor, we are a center of these things. If we don't detect, if we don't do our clinical ABCD tiroir, if we don't record, writing it as it is, readable, then no one will know what you write. And tomorrow we will find a lot of cases of MAMP in schools, and all those children have been passing in clinics, and no one ever reported. And tomorrow, parent, where is the vaccine? Where is the vaccine? How do we bring vaccine in the country? And you don't report it, and you don't write it. The vaccines will not fall from heaven. Yes, we will see the report. Yes, I will go into my system. I will see your reports per hospital. And I will say, I'm analyzing this. Oh, we have a trend of measles What can we do? How do we bring the vaccine? Situri kumwera dufite akazi n'ukuri kw'Imana. N'ukuri pe dufite akazi. So, the identification, the reporting, the analysis, dore aho ndi rwose. Ntangire kugaragara hano. Investigation. Amashuri, ayahe mashuri se? Mu Rwanda dufite amashuri angahe? Vuga where? Prepare, respond, communicate, evaluate. Then the MMR can come. Isn't it? These are the diseases that we survey every day. You know, last 2 days, I was training medical doctors that we want to deploy in the quarantine site. They were like 16. And I asked one single question. Why are you here? We came here for the training. Who among you ever click on Google or WHO to read about corona? Only 2 among them in 2 months of the corona. Only 2 medical doctors ever click on WHO to read about corona in 2 months. And I was like, what? Si ikibazo ra? Ni ikibazo gikomeye. Ni ikibazo gikomeye cyane. Niyo mpamvu corona tuzahunga. Kubera iki? Tuzi ko ari umuzimu. Yes. Tuzi ko corona ari umuzimu. Tuzi ko Ebola ari umuzimu. Ebola, corona, yellow fever, they are not ghosts. They are diseases that we as physicians, people will come into our clinic and we will face them. But if we miss something, oh, doctor, I have fever, I'm coughing. That's normal. We are in the flu season, isn't it? Did you ever been in China? No one asked the question. And then you breathe in. After tomorrow, he comes back to you. He contaminates you. I see, very serious. So it is a call for a joint action. The case definition that we share on WhatsApp, on emails. I don't know how many doctors have what you call the case definition of corona in his phone, or the algorithm of actions on his phone, because we send on emails, on WhatsApp, on Twitter, everything. RB's website full of documents. Everything is there on our hands. Now, let us use the resource that we have. Siko imeze banyakubawa. Izi nizo ndwara dusurvey buri munsi. So when you are sitting in the clinic every day, ask you a question. Among these diseases, did I find at least one? And if I found at least one, did I record it? Or ask the focal part? Because in every hospital in this country, in every health center, and some private, because the private you don't know sometimes when they use a vote education to be many. We have what we call IDSR focal person, who are in charge of collecting what you write and put into a system, an electronic system, by the way. This is where the system is implemented. I no longer update it because the number of health centers keep changing and so on and so on. So this is how the system is built. And the terms of references at every level of health facility within the country, the system is there. Please use it. And this is from where we came from. When we talk about outbreak preparedness, it is really a system thinking. It is complex. When we start, it was on the paper with the sticks and the diskette. Umuntu akava Kibogora, akagera i Kigali, akanyagirwa Nyabugogo, kandi yazanye information kuri flash. Yagera muri biro, flash yapfuye. Twendaga gusara. Ukavuga ntabwo tuzirinda ibyorezo dukora kenyeji. So we start from paper based. Then we move today. When they record, I get an SMS here. 115, I can see Kibogora, there is MAMP. But previously, it was paper-based and the diskette and so on. So this is like the journey. And this is what I call like a architecture. When we talk about outbreak preparedness, see system thinking. See the concern. When we say about concern, you know, I have receiving people in my office during the Ebola. Dr. Jose, we are fearing that Ebola will cross to Rwanda. I say, yes. And then what? If it crosses, then what? Don't bring me fear. Bring me the concern. Because once you are concerned, you will contribute. But if you bring me fear, you are telling me, be ready to run. And I'm not going to run. That is it. When we say we are fearing that it will cross, my dear, all borders are open 24/7. Which means I know that it may cross. But my question is, am I ready to face it? Because it's not, I like to say, if I cannot prevent, then I have to control. If you cannot prevent, be sure that you control. So that's what I say, the risk perception of the disease, the risk perception and the science of the disease. Because of the fear, the paranoia, the panic, the information epidemics, the science is being hijacked completely. Completely hijacked. You sit, you say, for me, I think I can do A, B, C, D. Someone say, how sure are you that is telling you the truth? Wow. I'm a medical doctor. I believe in what people told me. This is how I've been trained. And this is how those questions, when they comes up, you are no longer here, you start acting as. So the information technology and innovation. That's why you see at the airport, instead of using paper, we are using electronic. Because you cannot deal with this thing on paper, then your data manager record, then it's impossible. So you record, someone is analyzing, and so on. The decentralization policy and the community involvement. This is what I call normally the governance. We use all the means, from household to higher level. Everyone contribute at his level based on the existing infrastructure and the decentralization and the community involvement. Every outbreak starts in a household. Every outbreak starts in a household. Siko bimeze. Indwara zose zihera mu rugo. Nukuvuga yuko we need to fight disease from household. For information and information sharing, the partnership. When we talk about outbreak, many times we see public facility. But the history proves that most outbreak that we have and the alert that we receive come from private. The H1N1 was detected in this country from a private, isn't it? It was at King Faisal Hospital. The first suspect case was in Kichukiro last few days of corona. Yes, in Kichukiro, see big what? Bia bitaro biri Kichukiro higi. DMC, something like that. Aisha bundi hano kuri plateau, barakete umuntu. Which means private clinic, I don't know who organized them, who is here, but private clinic are of importance and concern. Because someone who traveled is not someone who went to health center, isn't it? Umuntu utagiye indege ajya mu Bushinwa ajya kwivuriza ku kigo nderabuzima. None se hari mu cyiciro cy'ubudehe cya karindwi. That is it. Of course, because someone who can go to Guangzhou, to Wuhan, to US, to Italy, cannot go for health center to get treated. Ntabwo akoresha mituweli. Akoresha UAP, akoresha RSSB, Mediplan, y'abasirikare n'ikiragenda. MMA, they go for private. Yes, they go for private. Are private facility concerned? Are they organized? Do they have tools that we shared? I don't know, but a concern, the risk perception, the ownership and integrity. You know, these outbreak when they come, bavandimu, ikiorezo kirasaba high level of integrity. Because it's also a business opportunity. It's also a money-making machine. If you don't look into this, you'll end up selling your country. I was in DRC for Ebola. I spent time there in those bushes and look into an outbreak and see what is happening there. The ownership, if you don't do for yourself, la nature a horreur du vide. Someone will come and cover what you're supposed to do. And you'll find becoming a visitor in your own country and system. So we need all to have that high level of honor. It is our matter, it is our country, it is our business. It is not NGO's business, it is our business. So this is for Ebola and the Corona. I developed this thing during Corona and Ebola just to understand the concept. All these diseases are not made in Rwanda disease. Yes, we accept if you can get them, they will be imported disease, which means they will use flight, they will use buses, they will use amaguru, they will use lake. So which means there is a flight, there is a lake, there is roads, there is everything. Napanya road. Zirahari. And this is every action that will be triggered. Port of entry, surveillance. Community, surveillance. Surveillance, laboratoire, contact tracing, rapid response team, case management and IPC, case management, barrio, hospital. Umuntu umwe ushobora kuzana icyorezo adeclansha reaction z'igihugu cyose mu nzego zose. So which means really we need to be very, very, very careful and concerned and to be ready to trigger all these things at the same time. That's why when we have this kind of outbreak, the first things we do it is to be able to do what? To test. In 2014, 13, 14, and 15, during the West Africa Ebola, we didn't get the capacity to test. I cannot say how many times people took flights to go to Uganda with the sample and they stay 3 days waiting for it and come back. Until we say, what the hell is this? Because some people used to say, you know, there are regional labs. Regional labs. And if that guy give me a positive instead of negative, will I believe him? That's why we say, for this Ebola capacity, we can test Ebola in this country. For this Corona, we did a miracle, by the way. Yes, because the Corona was born on 13 December 19. February 3 to 4, almost we had capacity to test it. And no one knows. I remember even some America says, how can Rwanda be able to test? Because we own our capacity. And we get it. And we can test in this country. Okay, these are the pillars. You cannot control an outbreak if you don't have the strategy. So number one, the coordination, the leadership, and the finance. Number two, the community mobilization. Umuturage n'urufunguzo. Number four, the surveillance. What we call the standard case definition. Corona niki, Ebola niki. Uzamenya gute umurwayi uri suspect, umurwayi uri probable, umurwayi uri confirmé. Byose twarabitanze sinzi niba mubifite. Twarabitanze mujye no kuri RBC www.rbc.gov muzabisanga. Abayobozi b'ibitaro twarabibahaye. Nibi byose mwabibonye. Beyond Ebola, beyond coronavirus. Normally, we should not run when there is an outbreak. Kubera iki? And you cannot mbivuga gutya. Urabona iyo inzu yafashwe n'inkongi y'umuriro. Akaba ari igihe ujya kugura kizimya moto. Uragaruka inzu yarangiye. Nukuvuga iki? Ubu ngubu turi kuvuga, ejo turavugaga Ebola. Ubu turi kuvuga Corona, ejo tuzavuga iki? Hazaza ikindi. We need to invest in sustainable prepare. Sustainable. Ntabwo ari inzu z'icyatsi z'nyakatsi zishya bikarangira. Nukuvuga iki? Infrastructure. Niba rwara se urabashyira he? Laboratoire. Yawe ipimiki simbizi. Workforce development, abantu bawe urabahugura. Abantu ko bamenyere ko muze mu mahugurwa bakaza per diem zigacika. OMS yashizeho urubuga burimo wese ashobora kujya akiga. Nibura ibizwi. Ni www.openwho.org. Please let us go and read. Jose never meet Corona. Don't look at me and waiting that I will teach you Corona. Let us all go there and read Corona. Siko imezera? community event-based surveillance, amakuru from household, community engagement, partnership, health system strengthening. Danger sasa Dr. Musabe yabivuze, tugeze aho yaba muganga yaba muturage twese dutwarwa n'ibihuha. Umuganga ntari gusoma corona, ariko kuri WhatsApp zo mudugudu ni wasomera corona. How come? It will not work. It will never work. Nimba a medical doctor is reading about corona on mudugudu WhatsApp group, then what? What is the difference? Because all those people, when they got sick, they come to you. So, ni ibingibi wabonye danger zihari na risk n'abanyamakuru n'ibindi byose ni biguruka gusa WhatsApp, Twitter, and then so what? Murakoze murakarama.
The next speaker is going to be Dr. Mugwaneza Placidi, who is working for RBC now. She has over 13 years of experience in planning, management, and evaluation, and the support of HIV prevention and programming. She has contributed to many programs and new initiatives at RBC. But prior to that, she has worked as a medical doctor in hospitals. So she knows what we are doing, and she is in different level. This is the person who really can give us a very good presentation on HIV in Rwanda. Welcome. Can we please welcome her with a very big round of applause?
Good afternoon. I'm pleased to share the presentation about HIV program in Rwanda. So my first slide will start by HIV landscape in Rwanda. For those who are knowledgeable of HIV program in Rwanda, we have, okay. Okay, I will start by the map on the other side showing HIV prevalence in Rwanda. So this prevalence, the overall we have 3%, but you have differences between provinces. So the map on that side is showing the prevalence as high as 4.3% in Ichigari, and this is the last study we conducted in 2019. But for other provinces, the prevalence is around 2.9 to 3%. As RBC and HIV, to make sure that we are planning properly for HIV program, we do conduct several surveys and studies. And on the other side of the screen, here you can see here. So these are the findings of behavior surveillance surveys that we are conducting among female sex workers. In my next slide, you will see why are we focusing on some group of population. For female sex workers, as you can see, the prevalence, the overall prevalence is 45.8%. But here in Kigali, you can see the prevalence is up to 55%. So as we see and receive those particular group of people in our in our consultation, we have to make sure that also we are checking for HIV. Another group that as HIV program we are doing regular monitoring is about men who have sex with men. The first study we did is to understand even the size. The size estimate for MSM in Rwanda is yet to be known. But we conducted the size estimation here in Kigali, where we end up by having 8,411. And among this particular population, we did HIV prevalence study, and here in Kigali, the prevalence is 9.2%. But the overall among MSM, the previous study we conducted is 4%. So these are key statistics in the program. The one that I want to present once again is mother-to-child transmission rate, where we do regular follow-up. And since 2013, the prevalence is less than 2%. But as a program, even if we can say, wow, this is the number of children, they're around 150 per year, which is still unacceptable for us. Yeah, the other program we have in HIV response is male circumcision. All of us, we know it can protect male up to 60% reduction of risk of HIV acquisition. So we do regular monitoring of male circumcision prevalence, and the latest study showed us around 40% nationwide. So these are data of HIV prevalence by age group. As you can see, across age group, HIV prevalence is high among female compared to their male counterparts. And looking on the residents, the overall, especially incidence, this is the last study, as I said, incidence in urban, especially here in Kigali, is 0.15, and the overall is 0.8 per 1,000. So to know what we have to do as a national program, we had to understand first who are the drivers of HIV epidemic in Rwanda. So we did a mode of transmission, and then we realized that majority of new infection in Rwanda, they are coming from stable heterosexual partners. Why is that? Because among stable heterosexual relationship is where we are having clients of female sex workers. And as I presented, almost 1 out of the 2 female sex workers in Rwanda have HIV. So you can understand why we have majority of new infection among stable heterosexual relationship in the country. So those was a little bit of a background of HIV in Rwanda. And then what do we have in place? So in place, we have a combination of intervention to respond to HIV infection, including both prevention and treatment services. And then you can see we are targeting key population, the groups that I highlighted with high prevalence, and then the general population. General population meaning that people who are not at high risk. So we have a number of intervention. We have care and treatment and support. We have condom programming. We have HIV testing services. We have education services, PMTCT program, VMMC, all those interventions to make sure that we are helping everyone to reduce the risk of HIV acquisition and to help those who are living with HIV to have a positive and continue to have a healthy life. So the good thing, in addition to having a combination of intervention, our services are available across the country and they are free of charge. So this is the map showing where we can have access to HIV testing services, PMTCT, and care and treatment services. So going one by one, what do we have? Especially I want to share the new in the program that we are implementing currently. So for HIV prevention intervention, the first one is HIV testing, because from HIV testing, everyone knows his HIV status. If you are negative, you keep preventive measures, and those who are HIV infected, they are enrolled into care and treatment. So HIV testing, normally we are focusing on HIV testing, based health facility testing, and we are recommending HIV testing through outreaches only for key population. We used to do mass HIV testing, but given the prevalence in Rwanda, it's no longer a recommendation because the prevalence is that low and the coverage within our health facility is that big. So the recommendation, we are discouraging really outreach for the general population. What's new in the HIV testing? We have introduced HIV self-testing kits. So someone can test himself or herself at home. This is the kit that we are using. We are using Oral Quick. This is available for free in some health facilities, but here in Kigali we have private pharmacies selling those self-test kits at 4,000 Rwandan franc. Also, as HIV response, we have introduced a new way to find people who are living with HIV in the community. And we call it active case finding. So normally, those who are tested HIV positive in our different health facilities, we are encouraging to discuss their sexual partners. And for mothers, we encourage them to bring also their children to make sure that they are being tested to know their HIV status, because those sexual partners of the positive cases, they have higher likelihood to be HIV infected. Another new strategy that we are having in place is to do a case-based surveillance. For those who are tested and being positive currently, we are doing a longitudinal follow-up to make sure that are they on treatment, the viral suppression, and so on. The other thing we have introduced recently, this is last year. Now, from those who are tested positive newly, we are looking those who have recent infection. And recent infection is defined for those people who got infection in less than 12 months. So we have specific kit, which is called Asante kit, which is a rapid test, so we can know from those newly tested among those one who have recent infection of HIV. So this is an example of cascade of index testing and partner notification, as I said, as one strategy that we are putting in place to make sure that whoever in the community living with HIV is identified. So like the example of, we started in 23 sites here in Kigali, and then we had 2,438 positive cases. And those ones, they have reported sexual partners around 4,205. But because this is a voluntary process, so the notification was done on 94.1%. I can give a little bit of explanation here, because case of female sex workers, some of them, they report sexual partners, but they don't have their contact. So even they don't know their name. For the program, it is even difficult to trace them in the community and invite them at the health facility for testing. And others, they fear to have like some violence. If we have positive feedback and screening of potential violence, we don't go into the partner notification to protect the index case. So from those whom we managed to notify, we managed to contact successfully 72.3%. Because some of them address they are providing, they are not the right one, their phone are not working. And this is the reason why we have a big drop from 94.1 up to 72.3%. Those who receive testing from the 72.3%, it is 86.9%. And what is the finding? Among those sexual partners of the positive cases, the positivity is up to 9%. But from routine testing, the seropositivity is less than 1%, meaning that this strategy is helping the program to identify really the people who are living with HIV in the community, even if it has its sensitivity. The last bullet is showing that as we have few cases now in the program, whoever is tested positive, we do a case documentation to understand together with the health facility what happened and lead to that infection. While they do have treatment, they have follow-up mechanism. So this to show prevalence among pregnant women. Normally around every year in the country we have more than 300,000 pregnancies. Among those one, the seropositivity is around 0.6%. And for those who are tested positive, the coverage of antiretroviral treatment is almost 97%. And for the children who are born to those mothers, the prophylaxis, RV prophylaxis is initiated, this is the HIV-free at 24 months, meaning that we follow all those children born to HIV-positive mothers up to 24 months. And we look on those who are still alive and who don't have HIV. This present 98.3%, present the survival rate of HIV-exposed infant followed in PMTCT program. We move to the voluntary medical male circumcision. I can see a majority of physicians here coming from referral hospitals, but this program is mainly implemented in in health centers and district hospitals. But majority of the cases are coming from those levels. And last year data showed us we managed to cover male circumcision up to 346,000 male. And as the program, we go ahead and we do analysis of the client that we have in the program, because normally this program has to target especially sexually active male to prevent the risk of HIV infection. On this slide, we did analysis by age category to see who are those coming to the services. And you can see majority of them in the age bracket of 15 to 19. So we are missing older men. So we are missing older men. We have to continue sensitization to say that they are at risk, because we have seen majority of infection are coming from the stable heterosexual partnership. And then we don't have them because, I don't know. We are trying our best to have specific day, like weekend, and then to separate with young boys, because they have complained. We can't line up with our boys waiting for male circumcision. So we are putting such a kind of strategies to make sure that we are increasing the number of those one in this age category. For male circumcision, currently we are using different approaches. The first one is conventional surgical method, and then we are having device-based circumcision. For device-based, this one is for infant. We are using for infant less than 60 days. And then there is a new one that I have not presented about. We used to use Prepex device, but it was phased out by the manufacturer. And now we are introducing the new one called Shang ring. It's the same principle of keeping the ring for 7 days, and then we remove the ring after 7 days. So another program that we have is for key population, as I said. We have different strategies, as you can see on this side. This is a condom kiosk. I don't know who have seen it. Condom kiosk. They are placed in strategic places here around Kigali and out of Kigali. Here in Kigali, we have one at Mirongwine, Nyamirambo. We have another one, Sodoma. We have another one in Imijina. We have another one, do you know Corridoro? Corridoro, nearby the airport. And another one at Nyabugogo. So here in Kigali, we have 5 of them. And out of Kigali, we have one in Huye, Kumukoni, if I'm not mistaken. Kumukoni, we have one. Rubavu, we have one on the Petite Barrière, nearby the Petite Barrière. And then we have one in Rusizi, nearby the market. So those condom kiosks was placed to make sure that people who are in those specific areas, you know, mainly Imijina, nearby RBC, is a hot place. So we have many female sex workers who are coming to those areas. So those condom was placed to make sure that female sex workers who are in those areas, they have access to condom 27 hours, 7 days of a week. So they're working 24 hours. So another thing, this is on the picture, love, this is a kind of lubricant. I don't know if you're using lubricant in your respective facilities, but as RBC, we are offering lubricant, especially for MSM. Yeah. So another program that we have introduced last year is about the other program is about the pre-exposure prophylaxis. Pre-exposure prophylaxis is given to negative people, especially who are in the high-risk group, and those one include female sex workers and negative partner and discordant couples. We have introduced MSM also to be a beneficiary of PrEP treatment. So this is a combination of 2 medicine, and those normally the recommendation by WHO is given to someone who have high risk, and when the risk is no longer there, we have to discontinue the treatment. And those are the categories that we are targeting currently. I think I have said a lot on prevention. Let's move to care and treatment. Care and treatment, what we have is about the new approach, especially to reduce the visit of people living with HIV at the health facility. And the idea is to reduce the burden both to the client and then to the health facility who are receiving many patients on a monthly basis. So we have this approach, differentiated service delivery model, where we have all patients categorized under between stable and unstable groups to make sure that stable client, they do have visit at 6 months, clinical visit, and they they have their pharmacy refill every 3 months. So we reduce the number they are coming to the health facility. And now the next year we'll be starting those, for those who are in the stable group, we'll be starting them to give treatment for 6 months. And then we continue community monitoring. So these are the eligibility criteria normally. For stable, patients are classified as stable when they are on the first and second line, and they do have 2 consecutive viral load suppression. And they do have good adherence, and then they have willingness to be part of stable group, because they are those ones who are not willing to take this big amount of drug at home. And then we have also, in the stable, we have 2 categories, as you can see. And the second category, the difference, they do have 3 months clinical visit and 3 months pharmacy refill. The difference is clinical visit. And in this particular group, you have adolescent, we have key population, and we have client with co-infections. Unstable, of course, there are new patients, less than 12 months in the treatment, because we don't know exactly if they are adherent to the treatment, and we don't have their consecutive viral load results. So these are the data of care and treatment for up to June last year. And we are looking on the new enrollment in the program. So overall, we have enrolled 13,959. And by province, you can see that the Kigali city, we have a big number. And then on this slide, the graph is showing normally we have estimate of people who need to be initiated on treatment by province. And then we wanted to understand from the estimated number of people who need to be on treatment, how many are we covering? So we can see the coverage by district across. Overall, we are covering 85.6%. On the top, we are showing the total number who was of people who are living with HIV who was on treatment, and this is by June 2019, because this is the period where we are developing our annual reports, meaning that this number has increased obviously. So I want to show you some data about normally treatment outcome, the viral load suppression. So this is the data from RFIA. I have highlighted the issue of adolescents and young people. So the people in the age category of 15 to 24, we can see across gender, whether female and male, the viral load suppression is very low, and the overall is 60.6%. But you can see as the age group increases, the viral load increase especially. So we have, I think is the next panel, we have to put more emphasis on adolescents to help them, especially they do have different reasons about autostigma and so on, and poor adherence that lead to this poor viral load suppression. Another slide that I want to share with you, you know that there is a global commitment to reach 90-90-90 target. The first 90 being the people who are aware about their HIV status, and then those who are HIV positive, among those 90% normally should be initiated on treatment, and 90% of people who are on treatment should have viral load suppression. So this is where we are as a country, and especially where we have a key gap is on the first 90. So meaning we are having people in the community who are HIV and they don't know their HIV status. So I'm going closer to the end of my presentation, just to share that this was presented from my first slide. As RBC and HIV program, we do different surveys to understand HIV epidemic in Rwanda in order to plan properly. So like the DHS, that is being conducted every 5 years, and now we have this specific HIV surveillance that is coming also for 5 years. And we have specific surveys for key population, like the one I mentioned, female sex workers, MSM, and we are conducting them every 2 years. We have the one on drug resistance, and I have presented the case-based surveillance. This is a kind of routine surveillance. So the finding from those surveys are helping the program to, normally we use for conference where we do present different abstract presentation to revise our national guideline and strategic planning for HIV. We have a specific HIV strategic plan for every 5 years, and mainly these serve as a tool for mobilizing funding and guiding implementation in the country. So key priorities for the program. So we still have to sustain the gain in HIV prevention and treatment, and then identify the gap, and to support areas that we are lagging behind, especially adolescents, as I highlighted. And we have some challenges. As I said, adolescents, we are not doing well as a program. We are not reaching men properly. And then even if we have all means in place, we still have new infection among children. And then the last one is the reduction of funding. Because majority of our program, even if they are free of charge, there is someone who is covering. And majority of those funding they are donor-based. So this is a critical issue in the program. I want to thank you for your kind attention.
Thank you very much, Dr. Prasidi. That was great. I will invite you to keep your questions because Dr. Prasidi Umugwaneza is going to be on a panel, or the next panel. You probably need to write down your questions so that you get a chance to ask. But for the previous speakers who talked about the coronavirus, Dr. Musabeyezu and Dr. Nyamusore, I invite you to write down your questions. You have pieces of paper. Please write down your questions and give me the pieces of paper. I will ask the questions for you because we don't have a chance to, we don't have time to have 2 panels, but I promise to do that. So we are going to, but before I introduce the next speaker, I also want to remind about the CPD. Those who didn't bring the books, you will receive certificates which also can serve to attest that you have attended this conference, so don't worry. Again, I want to remind about the cocktail at the end of the conference at Galaxy Hotel. And if you want coffee, you can go time and grab your coffee and come back to the room because we will not have time for break. My next task is a hard one. How do I introduce someone that everyone knows in this room? And it's someone who will beat all the odds, all the jet lag to make sure he comes and present. He just landed to Kanombe from the US. Professor Onyema Obwagu is a physician. He's an associate professor of medicine at the Yale AIDS program, section of infectious diseases, Yale University School of Medicine, New Haven in Connecticut, United States. He has trained most of us, most of the physicians I can see in the room, since most of us are young, including myself, when he was part of HRH since 2013 till 2018, and he keeps coming whenever there is an occasion. So Dr. Onyema leads several grants across Africa, and he's extensively published. Born in Nigeria, he is a proud son of Africa, and he calls Rwanda his second home. He has 3. He insisted that I put in his bio, that I mentioned that he has 3 lovely and lively children. And if you had met them, as I had a chance to, there is no way you couldn't agree more.
All right, so I think you're going to learn a lot of new things. So I want to prepare you now. I'm going to throw a lot of stuff at you, telling you about the recent advances. It was impossible to talk about everything, but I've highlighted some very key, groundbreaking, game-changing, really critically important things I want you to pay attention to. Now, many of them will not be available here in Rwanda. Some of them might be coming down soon, but I want you to just see where globally we're heading towards HIV eradication and cure. And I think you'll be very excited about some of the things I'm going to mention. So again, to just thank you all for bringing me here. I totally agree. Rwanda is my second home. And I memorized this, right? So, Indishimye Kugaruka Murugo, right? Thank you. All right, so some disclosures. So these are the key points I'm going to go through. So we'll talk about HIV vaccines. And I'm sure many of you know that the HIV vaccine trials are being done where? In sub-Saharan Africa, right? So we'll look at some of the studies that have been done. And we're very lucky that of the 3 ongoing vaccine trials, we already have results of 1. Okay, so put your seatbelt on and get ready for the drive. We'll talk about HIV cure as well, and I'll be sharing with you the latest HIV cure that occurred, and I'll tell you what I think is possible and what is not possible, and at least we'll have some lessons learned from that. So we'll see if it's something that's scalable or not. I'm not going to talk too much about 1990 or 95, 95, 95, but I'm going to approach it from a system public health standpoint and give you throughout some new ideas on how we can better refine our approaches to get to those targets. And I can see Rwanda, you guys should be aware that Rwanda really looks good compared to so many other countries in the world. I mean, when it comes to 90, I think many countries in sub-Saharan Africa. Now, West Africa is terrible, okay? But it's really Eastern and Southern Africa that are leading the way with HIV. West Africa is horrible. I'm currently working in Liberia, and they are in the dark ages when it comes to advancements with HIV prevention and treatment. So Rwanda is doing really well. I'm going to talk about modeling, which is, again, one way we can leverage technology and software to refine some of the public health work we do. And I'm sure RBC is working on some of those, and I saw some of your maps, so I may not have to repeat some of those. And then I'll talk about new HIV treatments that either have been approved or are going to be approved soon. But you will see that the era of taking 1 tablet once a day orally for HIV will soon pass. So I know we're all very excited. We're rolling out dolutegravir here, right? Because we know it's a great drug, very well tolerated, minimal drug-drug interactions. But elsewhere in the world, we're already fed up with single tablet regimens. We have at least 8 or 9 single tablet regimens. So maybe you have efavirenz 3TC TDF and you think you're special, or dolutegravir 3TC TDF. Trust me, we have so many single tablet combinations. Now we're asking the question, do people need to take a tablet every day for HIV treatment? I can't present all the data, but I'll present 1 or 2 to showcase that. And then the last thing I'm going to mention is HIV prevention. And I'm happy to see that PrEP has just started rollout here. So I'll just give a few updates on that. So that's kind of what we'll talk about. And hopefully I can do this in 20, 25 minutes, if possible. I know I talk fast, so just do this to me if you think I'm going too fast or you want me to repeat something. Yeah, that's what they said. All right, so I always like to make fun of myself, right? But I think it's very sobering to start when we're talking about progress in HIV. It's a very sobering reminder that every HIV infection is preventable. Every heterosexual transmission, right? Every transmission by, to, or from a sex worker, every transmission from a mother to child can be prevented. So how well or how poorly we're doing with HIV prevention and treatment is a reflection of our healthcare system, right? So if the numbers are good, we are doing something right. And we know how the community healthcare worker model has really been really effective in Rwanda, right? So every HIV infection is preventable. And I think when we need to, as medical providers, bear that burden that in many ways, especially since we're on the front lines of disease management and prevention, that we can do so much better to make sure that we can eliminate HIV, right? To get people protected against acquiring HIV. And so that's why I need to emphasize the 2 forms of biomedical prevention, right? Big categories. Pre-exposure prophylaxis, which means you pre-identify people who are at risk for HIV, manual sex with men, heterosexual partnerships, especially when the infected partner is not treated and virologically suppressed. We need to think about ways to identify those individuals. I know someone threw out the number here that there are 8,400 MSM in Kigali. You need to find them, okay? Because we know that they would have a higher HIV positivity rate than other risk groups. You need to find them and give them PrEP to prevent them from acquiring HIV infection. So again, there's no standalone strategy. There's no one way to fix things. It has to be a combination, a package, a group of interventions if we're ever going to be successful. And we have to attack the epidemic from 2 sides. It's attacking people who are infected and making sure they're suppressed, and then also going from the prevention end and make sure that people who are at risk for HIV are protected against acquired HIV. We have to do it both ways. And then for those of you who are dreamers in the room, this is what we're then looking for. This is like the holy grail, like the real thing that we really hope can happen. So if we had an effective vaccine, then why would we even worry about telling people about condoms? We just say, go to Nyamirambo, party all night, right? Do 10 mutsig and come home at 5 a.m., right? If we had a vaccine, that would be great, right? So that's the elusive target for at-risk populations. And then for those who are infected, wouldn't it be wonderful if we can achieve a cure? Because if we could cure those who are infected, then we could decrease the pool of individuals in the community who are carrying virus, and we can decrease transmission. But I put those two apart because those two things have not been achieved. And certainly, even if there are one or two successes, definitely not on a large scale. So, I just wanted to show you this slide to show you just how many people have engaged in vaccine studies. There's about 13,488 people that have participated in at least one vaccine study, phase 1, phase 2, phase 3 studies. It's crazy. Now, who knows a downside of being a vaccine study participant? So if you're HIV negative, you get a vaccine for HIV. What can it do to you that may be negative untoward consequence? What? A positive HIV test. Think about it, right? If you get vaccines for HIV, you develop antibodies to HIV antigens. And how do you test for HIV? By checking antibodies to HIV antigens, okay? So depending on the type of vaccine study, anything from about 9% to 90-something% of vaccine trial participants would always have a positive HIV test. So that the way to then screen them for HIV will have to be a viral load, okay? So whenever you get a positive test and someone tells you, I have no idea how it happened, if they're not a true total liar, okay? The other thing is that you want to ask them, hey, by any chance, I don't think Rwanda has been involved in any of the vaccines, but there's a lot of traffic. You have people who come from other parts of the region. That's interesting. Okay, so let's start with some bad news, okay, which is really the only news we have. So the Uhambo study, it's a South African tribe language, which should mean progress or way forward, was a phase 3 result that looked at an HIV vaccine. I'm not going to go through all the data, but what it simply was the viral target that was GP120. Okay, so GP120 was the viral target, so they gave people vaccines, and so they enrolled about 5,400 South African adults. They actually completed enrollment by last year or so. They completed enrollment in the study. Now, when you do a vaccine study, they were planning to look at those who would get infected. The endpoint was within 18 months. So you give people vaccine or placebo. And didn't think there is a saline placebo. So vaccine or placebo, sexually active adults, and looked for HIV infections in 18 months. So they're hoping that by the time people get vaccines, they generate immunity and it protects them, and you want to look at the end point at 18 months. But when you design those studies, usually you have a data safety monitoring board who, like every 6 months, sometimes every 1 year, looks at the interim results before you reach the primary endpoint to see if there's excess harm or excess benefit in one arm, because then it becomes unethical to continue the study. So for example, if there's 0 infections, even if you've not made the primary endpoint in the vaccine arm, and 20 in the placebo arm, you can't continue that study, right? Because you're already seeing efficacy, even if you haven't gotten your statistical endpoint, right? So the data safety monitoring board actually found that there was no difference in the study arm. So 123 out of 2694 in the study arm, 133 out of 2694 in placebo arm acquired HIV infection, no effect. So the study is halted and stopped. It's prematurely terminated. And this was a news release just last month in January. Okay? Now, the reason why this vaccine was so exciting was when they gave it to humans in the trial, the pre-trial before the phase 3, they found that it stimulated a lot of antibodies. So it's not like the vaccine didn't work, but HIV finds a way to modify its proteins and evades vaccines, and so it can be very frustrating that you've identified a target of the virus, you have people develop antibodies to the virus, but it doesn't lead to protection. That can raise a whole different set of questions. Does the antibody get to mucosal surfaces, right? Do you have enough antibody in certain, places where people are exposed, in the vagina, in the penile tissue? Do you have enough antibodies there? So there are many reasons why it can fail. Sometimes it's a pharmacokinetic issue, it's a distribution issue, and things like that. But it's very, very disappointing that the first vaccine trial has been terminated. So just to give you some hope, there's 2 ongoing studies now. So there's the Imbokodo study, it means strength of women. This is now enrolling individuals from multiple African countries, South Africa, Malawi, where now Zambia, Mozambique, reproductive age women, 2,600 women, and again, using a vaccine that's targeting GP140 and using an adenovirus vector. I'm not going to go into those details, but this is ongoing as well, looking at high-risk women to see if they can be protected against HIV infection. And I think, like we've seen in Rwanda, like it is in Southern Africa, in this part of the world, women tend to be have higher rates of infection than men, right? Tends to be epidemiology. There's another study, but this one is is in America and Europe. So we have a different kind of HIV, clade C virus here, and we have clade B virus in other parts of the world, and sometimes there can be differences in, how those different clades behave. So this is a study just looking at the same vaccine in Western countries where they have a different type of HIV. So we can answer the question, if the vaccine works, is it something that works for clade C and clade B viruses? Okay, I told you there's a lot to come. Now let's move on to HIV cure. So remember there's 2, when we use cure, and this may disappoint some of you. I know we think of cure as getting rid of and eliminating something, so nothing is left. But unfortunately, in HIV medicine, it doesn't always mean that. So there's 2 kinds of cure. There's functional cure, which means there's no ongoing viral replication, but HIV could still be hiding in the patient's cells. And then there's the true sterilizing cure, which is you're totally getting rid of it. So both the virus and the virus in the cells are eliminated. Okay? Now, the reason why HIV is hard to cure is we know that the antiretroviral drugs take care of the circulating virus. Okay? But the latent virus that's incorporated, so you know what HIV does? HIV literally comes in and puts itself in your chromosome. That's it, in your genome. That's exactly what HIV does. So HIV reverse transcribes itself into DNA and fixes its DNA into your DNA. That's exactly what happens. So an HIV-infected patient is carrying HIV in their DNA. Now, that HIV in their DNA can do one of 2 things. It can decide to sleep there and be latent and do nothing for many years, or it can replicate and produce virus that we detect in the blood. Okay, so we can always get rid of the one in the blood, but the one in the cells is very difficult. And then you can imagine that any strategy that we try to design to attack the cells with the virus can cause collateral damage, right? Because your immune cells, your CD4 cells, your macrophages, your monocytes, you need those cells for immunity. Okay, so it's a very hard thing to think about how can we get rid of HIV in cells that we need, and that's why sterilizing cure is hard. So I think that there are many HIV experts who have spent their whole life working on HIV, including the lady who discovered the HIV virus, okay, Françoise Barré-Sinoussi. She said she doesn't think that there will ever be a sterilizing cure for HIV. Okay, but most of us think that a functional cure is possible. We also have 2 definitions of vaccines too, and I don't know how much to go into, but we think of vaccines as someone doesn't have an infection, you get a vaccine to prevent getting the flu, coronavirus, HIV, right? But we also have therapeutic vaccines. So in the field, we think that you can actually give people a vaccine to make them produce antibodies to suppress their own virus. So this is something you can actually do for an HIV-infected patient. It's a therapeutic vaccine. So you can actually give them a vaccine so they endogenously produce antibodies that suppresses their own virus and they don't need antiretroviral drugs. Do you get that? It's fascinating. Okay, so that's a therapeutic vaccine. So you already have the disease, but let's see if we can help you develop your immune system to attack the virus without needing drugs. Fascinating, and people are working on that. So functional cure will be possible. I have met Timothy Brown. He's actually come to my institution to talk to us. The first guy who was cured of HIV. He's now, 12 years, 13 years. He's cured of HIV, he's still having sex, he's on PrEP, right? Can you imagine? He had HIV, he's cured of HIV, and he's also having fun, so he's actually on PrEP to prevent him from getting HIV again. That's how cool life is for him, okay? He's a very fascinating, he loves to come to conferences and talk. I met Musa Bezu in Croy, right? You came to, I don't think Timothy Brown was there, one of our big HIV conferences. So there's a second HIV cure, but before I mention the second HIV cure, this slide doesn't come off well. But so there's a second patient who, okay, let me just get through this. I just want to be conscious of time, but I want you to follow me along. So For Timothy Brown to be cured, 2 bad things had to happen. One is he had HIV, and then in addition to HIV, he had leukemia. And guess what? So you can treat the leukemia with chemotherapy, and one way you can sustain remission is after you cure the cancer cells, right, bad in the bone marrow, then you can kill those cells and give people a stem cell transplant, right? And then that now creates an opportunity for you to engineer the kind of cells you give back to the individual. So about less than 1% of all white people, sorry, this is one thing we blacks also suffer from, have a genetic mutation. They don't produce CCR5, which is required for HIV to enter cells. So they're homozygous for it. Okay, so 1% of the white population cannot be affected by HIV theoretically. So what you do is you get blood from those individuals, and then when you kill off the cells in the infected patient, then you transfuse them with those cells, and that's those cells, because they're pluripotent cells, they form the bone marrow cells. Now, you will really like this, okay? So now, the first set of studies was talking about giving a real human being something to knock off their cells and give them transplant. This is a very interesting animal study, and this was where they actually showed a proof of concept of how you can actually eradicate HIV without even having someone have to have malignancy. And so what they did is that they combined the use of antiretroviral drugs. So this time they used quadruple ART. So they used a lot of ART. So it wasn't just the 3 drugs that we used, they used 4. But they used long-acting, slow release that is able to get into different compartments and cells. And in addition to that, they use a very unique, what they call a CRISPR system. I'm not going to go too much into it, but CRISPR is essentially like a knife that can go in and cut out HIV sequences in cells. Okay? So remember we talked about getting rid of the plasma virus, but also getting rid of it in the cells. This was a combination approach where you can give people antiretroviral therapy, bombard them with it, and then use this gene editing system to cut out the HIV from the infected cells. Doesn't that sound really great? So this is a proof of concept. This is Nature. So Musa Beyes said we have a lot of respect for Nature, Nature journal, right? Okay. So I'm going to just fast forward to this. Okay, so these are the results. I cut off some of these. We can fast forward. So they did this on 7 mice, and they found that 2 were actually cured of HIV. And it was very, very exciting. And they had an 80% efficiency, which means that the CRISPR was able to cut out HIV 80% in 80% of the cells that were there. Okay? They repeated the experiment, and they, with 6 mice again, and they found that they were able to cure 3. So they were refining their approach to increase the success rate. Okay? And then what they did was to prove that the HIV the ones who were cured of HIV were HIV free. They took their bone marrow and implanted it into other animals to see if they could infect them, and those other animals did not get infected. That's another way to check, is there a virus that's hidden that we're not measuring, etc. But the reason why this is so exciting is that this now forms the basis for a possible approach for HIV cure in humans, okay? That we can use a combination approach of antiretroviral treatment and gene editing. Did you guys hear about some crazy Chinese scientist who gene edited babies, right, the embryos, and there were babies born that could not be infected with HIV, right? It was unethical, and he got in trouble in China. What he did was he found embryos, he did the technology, cut out the CCR5, and just, so that those babies were engineered and born and designed to be resistant to HIV. Isn't that really cool? It was unethical, okay? All right. So again, I think that's done. So people have already moved this to human trials. So there was a patient with ALL. So you know how people can also get autologous stem cells. So you have, when you treat the ALL, they get better. You can take their own stem cells. The advantage of that is that if you use someone's own cells, they don't need to be in a lot of immunosuppression. I know those of you who manage kidney transplants, you get it, right? You guys ship everyone to India and then they come back. Right? 6 weeks of dialysis. After that, you either die or get a new kidney, right? That's the Rwanda model. I'm just joking. All right, so Joseph, give me the look. All right, so 5%. So this guy who had ALL, right? So what they did was they did an autologous transfer and tried to gene edit his cells. It only cut out HIV in 5% of his cells. So it was very, very unsuccessful. So maybe they just need to refine the way they do in humans. But this is starting to tell you that we are actually starting to move the needle a little bit slower to starting to be able to develop a strategy to cure infected patients without having them to go through high-risk procedures to get that done. So stay tuned. This is really hot and exciting and holds promise for future investigation. So now let's just switch gears to, this would be the third out of 5 themes I just want to highlight today. So public health approach to end HIV epidemic. 90 is just math. If 90% of people with HIV know their diagnosis, 90% treated, 90% suppressed, 73% of all HIV people in that country are virologically suppressed. If you push it to 95, is about 85% of the entire HIV population are virologically suppressed. What that does, if we achieve that globally, or in your country, or in your healthcare facility, or in your village, right? What it means is that you can halt new HIV cases to the point where HIV ceases to be an epidemic. So you know how the World Health now is like waffling, like should we say coronavirus is a pandemic? It hasn't like affected 100 countries yet, you know, and many of us are rolling our eyes like, you know it's gonna get to 100, right? It's a matter of time. A case is definitely coming to Rwanda. Nigeria just reported their first case yesterday of someone who left Italy and went to Nigeria. So Nigeria has their first case, and then they're quarantining all the people he met and the hospital he went to. So it's a matter of time. Coronavirus is going to go everywhere, okay? So that's a pandemic. So there's a definition of about maybe 200, 250,000 cases every year globally. If it falls below that number, new cases, we can then no longer call HIV a pandemic. So when we talk about ending the epidemic, again, some of these things we say are misleading. It's not eradicating HIV from a generation. It's just having it drop to that threshold where it's no longer perceived as a public health threat. Numbers matter, okay? Treating 100,000 people HIV or treating 200,000 HIV, it's a big difference, right? It's tasking resources. One of the issues we've had, antiretroviral therapy works really well. People who have HIV who are on antiretroviral therapy can have near normal life expectancy. What is it doing to African countries? The number of people living with HIV will continue to grow because deaths are no longer happening. So if you think you're struggling to treat the ones you have now, wait 10 years. And see what those numbers will be. They're not going away. So in some ways, we're a victim of our own success. Antiretroviral therapy is doing well, so what does that mean? We're going to have more numbers, and that's a good thing. So it's all about resources. So this is where the epidemic stands. I think there's been some progress, 1.7 million instead of 2 million. And apparently, when it comes to the first 90, you guys are like looking good, although the numbers she presented didn't look this good. But based on the UNAIDS data, it looks like the Rwanda was about 90% testing. But I think that the one thing I always like to emphasize is that universal testing is not just a one-time testing for everyone, it's repeat testing for people at risk, okay? So there's some people who need to come back to the clinic every year. People who men who sex with men, people who are substance users who we don't readily identify in these settings, you know, people in heterosexual relationships where there's serodiscordance, you need to do that as well. So I think mopping up that extra 10% will take very, very innovative strategies to achieve. Okay, now let's talk about modeling. And I think this is really important because modeling is playing a great role in really answering the question, as a country, as a town, as Kigali, what kind of resources do we need? What interventions should we focus on? And when we do, what's the impact of those interventions on outcomes? Outcomes like mortality, would people die less? Okay, what's the outcomes on healthcare utilization and resources that are needed? So I wanted to show you examples of what it looks like. So in the US, this is modeling. If you look at this line, this thing's not showing. This is what the new cases will be every year if we keep current things done. But if you achieve 95, 95, 95, you can drop new infections to this level. If you now achieve 95, 90, 95, and you add PrEP, you can drop new infections to that level. So you can even test hypotheses like if we get 90, 90, 90 versus 95, 95, 95, what's the impact it's going to have on new HIV diagnosis? You can even add things and say if we get 90, 90, 90 and we do 10% PrEP, this would be the effect on things. And that's what this one is. 20% PrEP, 30% PrEP, 40% PrEP. So you can actually model, so you can really answer the question, like what is going to be the impact of these public health interventions on outcomes that we all need. We all need this kind of data, you know, to be able to inform the work we do. Same thing here. All right. So there's hope, though. So this is the number of resources. So I know someone talked about funding for HIV going down, right? And we know a lot of it is international funding. The US donates a lot of money through PEPFAR. There's USAID, there's so many agencies that support HIV work in Africa, and many of us are so dependent, right? I remember at some point, 50% of Rwanda's healthcare expenditure was foreign aid, right? I don't know if that's changed, right? So we're all very heavily dependent on funds, and we lose those funds, our public health interventions disappear. And beyond that though, that anytime, we make progress in HIV and we think we've done well, but just you wait when we lose funding and you close the condom distribution places and you close the programs where people get PrEP and you close that, what will happen to incidence? It will go back up. So there's almost that perception that we've gotten rid of a disease, we've taken care of it, it's no longer an issue. Just you wait. Just take away that sustenance of interventions, you'll see a rebound in those infections, and that happens over and over again. So it's not time to rest and relax and say we're doing really well. It's for us to make sure that we continue to use resources efficiently. But the good news is that at some point, if we're able to prevent infections, then the amount of money we need would not longer continue to go up, okay? Because we have a stable number that's retained, less new infections, and by having less new infections, you prevent healthcare expenditure down the road, okay? Diagnosing someone the first year they acquire HIV is much cheaper than diagnosing them when they have cryptococcal meningitis, and then treating them, and then managing all kinds of comorbidities for the rest of their lives. That's how to think from a public health standpoint. So, things I will just mention here before we move to the next thing is, again, we need to do better with ART utilization. Nowadays, there's test and treat, which is really good. And we know that since they changed the CD4 guidelines, everybody's being treated for HIV. But we used to think that since we've done test and treat, because we get more people into care and treat them fast, that would affect the incidence of HIV. But actually, there were like 2 studies that were just published recently that showed even in areas that had high test and treat coverage, that the impact of HIV incidence was negligible, which was very stunning. So that you were engaging more HIV-infected people in care, but the incidence in community was not changing. So it's very hard to understand that. Yes, very, very puzzling, okay? So I even wrote a letter to the journal when they published this from Africa. Of course, they didn't accept it because they thought I was crazy, okay? But I put the thing here. So in communities, there are spreaders and super spreaders, okay? There are people who have HIV that are not having sex, use condom every time, they're not spreading HIV. But there's a subset of people living with HIV who are super spreaders, right? Like they are like careless, out there, no condoms, spreading it to anyone they possibly can, okay? So if we reach all the people who are not having sex or using condoms and put them in the number and say we're getting those people on therapy, do you think it's gonna change anything in that community? No, you need to identify who is that patient X or Y in that community who's a super spreader. So that's why I put this little chart here. Like it's really, really interesting, right? So this is a super spreader. Right? Look at this. Look at the ring of sexual contacts he's had, and then secondary sexual contacts. There are people like that in our communities. Oh, these slides don't come up here. Anyway, so the big things here are, we've talked about PrEP, male circumcision, okay, and treatment as prevention, right? So those are biomedical approaches that we know that have a huge impact. So I just wanted to mention that we know that you can use 2 drugs, not 3 drugs now, to prevent HIV. I think everybody here knows what PrEP means, pre-exposure prophylaxis. Okay, pre-exposure for prophylaxis is identifying HIV-negative individuals who are engaging in behaviors that put them at risk for HIV and giving them a pill to prevent HIV. Okay, so use your contraception mindset before you get judgmental here, right? Okay, because we use contraception for women, right, to prevent pregnancy. We don't stigmatize that, right? Right? Sometimes we do, right? If you give contraception, it means they're having a lot of sex. All the fathers in the room are looking very uncomfortable, right? Okay, but that's also a barrier when it comes to things like PrEP. So it's really identifying people at risk for HIV, and I'm very happy that there's 10 pilot sites that RBC is reporting, targeting female sex workers and people in serodiscordant partnerships, because that's where the burden of HIV transmission is occurring. We need to scale that up. I just wanted you to know that there's actually a new product for PrEP that we are using. So we know that many of you know TDF, right? Tenofovir disoproxyl fumarate. It does cause bone mineral density declines, right? So it can cause osteopenia and osteoporosis with long-term use. It can also cause renal disease. So many of us know about the Fanconi's or the proximal tubulopathy, right? We all know that. It's not common. Like you rarely see it, but it does happen. So there's a newer form of tenofovir that we used, so it's called TAF, or tenofovir alafenamide. We compared that to tenofovir disoproxil, so the drug you have and the one you don't have, for HIV prevention, and showed that the one, they were essentially non-inferior. But the beautiful thing is that, you know, the study showed that when it comes to things like bone mineral density declines, while the newer one actually led to increased bone mineral density, the tenofovir that you are probably going to use was leading to lower bone mineral density. So bottom line is that there's a safer pill for HIV prevention, and that's really, really important. Okay, and I just wanted to showcase, you know, I've worked with many of you guys here, and so this was a pre-implementation survey where we did a PrEP survey both among community members in the community and among providers to start to ask the questions like, how do you think HIV is transmitted? If we had something to give you to prevent HIV, what form would you want it to take? And if we were going to give you PrEP, what are the barriers that you would face? Okay, so shout out to Kambutse, you know, and the Iraneza, you know, who were on that study, and the results were published showing that there's, you know, quite significant barriers, both provider level and client level barriers that, you know, that you faced in Rwanda. But I'm happy to hear RBC has rolled this out. But the challenge with PrEP is not just to do a pilot project. The challenge with PrEP is to scale it up to the point where it starts to have a public health impact. I'll give you an example. So, you know, the HIV epidemic in the US is driven by men who sex with men. 2/3 of, you know, people, new infections are among men who sex with men. There's been a 50% decrease in new HIV cases among men who sex with men because of PrEP utilization, where they've used it very much, okay? So this is the tool that we should really start to think about, okay? Throw off your judgment hats, you know, because sometimes everyone says HIV is behavior related, control the behavior, why do you need a medication? Come on, people are doing stuff, they'll do stuff anyway. Okay, so let's, you know, utilize and expand this tool that's evidence-based to prevent HIV infections. Now, you guys are really gonna love this, okay? So let me introduce to you some new HIV treatments. Remember I told you that taking one pill once a day, single tablet regimen is good, okay? But if it were a car, it would be an RAD. No, I'm just kidding, to be RAC, right? Maybe? RAB is newer, how is it now? RAD is newer, right? Than C. Remind me, C and D, which one is newer? Huh? C is older than D, fine. Okay, so single pill regimen is a C. So let me introduce you to RAD cars. Okay, this is the kind of car you want to drive. Okay, so the thing that has really changed about antiretroviral therapy is just, again, recognizing new targets for the virus. Okay, and new modes of deliveries. So I'm not going to talk about a lot, but I want to introduce you to one that will be approved soon. So the longer-acting HIV treatments. So cabotegravir is like dolutegravir. Rilpivirine is a second-generation NNRTI like etravirine that we use as third-line drug. So it's a non-nucleoside reverse transcriptase inhibitor and an integrase inhibitor combination, long-acting for treating HIV. The reason why they chose these drugs is that they have very long half-lives. So for example, when you give this intramuscular injection of cabotegravir, the half-life is 40 days. If you give intramuscular injection of rilpivirine, the half-life is 90 days, okay? So these drugs can be dosed once a month or once every 2 months, okay? So what I want to show you study results on are on comparing people who took a pill a day and stayed on it compared to those who went on long-acting therapies. Okay, I'm not gonna go through the study design, but this was the outcome, okay? The fact is that for those who were on regular single pill regimen, suppression rates, you know, at 48 weeks, which is a year, was 94%. Those who went on long-acting therapy was 93%. Okay, and they've submitted this for approval as a HIV compound. Okay, so many people will ask, do people complain about injections, et cetera, but when they did, you know, qualitative surveys, right, they found that up to 90% of participants says, you know, I get the needle, it hurts, but, you know, I can deal with it and I can tolerate it, okay? So very soon, there's gonna be long-acting therapies for HIV treatment. Think of what that does for adherence, right? It's very difficult to remember take a pill a day. And also, I think you may think about an injection, how it's going to, you know, people can't give themselves IM. You can give sub-Q, but IM is very difficult, right? You have to go to a clinic. But then it now provides an opportunity then for clinics to support adherence, right? Because you can have people come at pre-scheduled times and people get their injection and they're fine for a long period of time. I'm helping a pharmaceutical company advance another compound that has a 6-month duration. So you can dose it once every 26 weeks. It's crazy. Okay, so we already started clinical trials, early stage clinical trials for that. So I know it takes many years for treatments to get to Africa, right? We've had dolutegravir for a long time. Now we're rolling out dolutegravir, although, you know, the pregnancy thing was an issue. You still don't use dolutegravir here? Oh. None, wait. Okay, anyway, so anyway, it may take a while for them to get here, but I want you to know where the therapeutic field is heading to. We're no longer satisfied with one tablet once a day. We want to push the envelope for oral therapies, parenteral therapies that you don't have to take every. Okay, we're almost done. Now, I told you about antibodies, right, and suppressing the virus, okay? Remember I told you about therapeutic vaccines, okay? Now, this was a form of passive immunization. So even though this wasn't a vaccine, then you produced the antibodies, but this was an externally delivered antibody. And the question was, could you get people off of taking their HIV medications and keep them suppressed on an exogenous administered monoclonal antibody? Now, those are very, preferred because they don't have as much side effects as antivirals. There's nothing like viral resistant per se. So this was in the New England Journal of Medicine last year. This is an antibody against CD4. So this is a CD4-directed antibody, okay? So what they did here was very clever. So they just found people who were virologically suppressed on their antiretroviral drugs, okay? And they decided to do treatment interruption for 8 weeks. Okay, and when they did that for 8 weeks, because you know that if you stop anybody who has HIV on treatment, usually within 8 weeks, the virus comes back, right? If you stop medications for people with chronic HIV, 8 weeks, almost 100% of people have virus in their blood detectable. So what they did here was they stopped the ART and gave them monotherapy with the monoclonal antibody, either weekly or bi-weekly, 8 doses of that, and then they checked to see who was suppressed. The study reported that out of the 27% that completed the study, 100% of them stayed virologically suppressed after stopping antiretroviral therapy. So proof of concept that an antibody-based therapy can keep people suppressed for long periods of time. Okay, all right, so let's do our last slide. I know I rushed through this. Okay, so again, it's exciting that this can happen. One of the beautiful things about the antibodies, like I said, is that if you can then find a way for, if an antibody keeps people suppressed, to vaccinate people to produce that same antibody, then all of a sudden you've created a functional cure because people can suppress the virus without having to be on antivirals, which is amazing. So let me just summarize here. So again, they are effective vaccine candidates, but the current ones we found haven't really worked yet, but there's still at least 2 trials that we're going to learn a lot from. Now, if I told you, let's say the study comes out and says that a vaccine has 50% efficacy, okay? So 50%, okay? So 50%, it fails 50%. Would that be good enough for you? Better than nothing. So here's how I put it. From a public health standpoint, so RBC will be in love with it, right? Because 50% at the population level means having new infections in Rwanda. But on an individual provider level, when you and me are sitting with the patient and we're telling him you have a 50-50 chance that this vaccine will protect you from HIV, what are they going to do? They're going to say, give me PrEP, right? So do you see the difference? So do you see the conflict there between how the same data is perceived differently from a public health approach and from the individual provider approach? If someone tells me a vaccine is 50% effective, I'll say, you can give it to me, but give me something else that works well, okay? So then you can now see that the standard for an acceptable, successful vaccine is higher than we think. It almost seems like it has to be 75%, 80, 90 for us to be accept it, and then our HIV programs then incorporate it and recommend it for use. So the bar is set so high, and that's one of the concerns about vaccine development. We've talked about cure, that functional cure is much more achievable than sterilizing cure. The people who got sterilizing cure had to have a malignancy or cancer, but there are new gene editing techniques. There's even more technologies beyond CRISPR where you can try to cut out the HIV from infected cells, and a lot of people are spending their lifetimes working on that. So just know that that's in the pipeline. We've talked about PrEP, which is really important. We need to do better. We need to, the pilot studies are ongoing. We need to scale up PrEP. It's not enough to do 10 sites. It's enough to find out who is at the highest risk for acquiring HIV in Rwanda and get them to use PrEP. Okay, and there's a lot of barriers to overcome, but we need to do that to have it have a true public health impact. We talked about long-acting therapies, and I thought because of coronavirus, to remind you. So let's assume we did very well with HIV in Rwanda, right? So Rwandans only have sex with Rwandans, right? Probably not, right? Exactly. So Rwandans and people moving to Rwanda. So globalization has made a mess of disease control. So you can never think of yourself as a silo or in isolation. So sometimes your public health interventions can work locally, but you lose some effectiveness because you have some contamination or from external environment. So that would be a constant tension for public health efforts, and that would be a challenge. So there's no coronavirus in Rwanda. It just takes one person to bring it here, and all of a sudden, all hell breaks loose here. Now, this is totally me talking, okay? This is really important. I think that one of the greatest things we need to do regarding HIV is to eliminate stigma. Stigma is this barrier on so many levels that has really, as an HIV provider myself, it's very, very frustrating to just see the way we perceive HIV, and so, stigma makes people feel uncomfortable telling you what they do because they'll feel they'll be judged, and that's why they're not getting tested. That's why they won't ask for PrEP. That's why they won't go into HIV programs, okay? Stigma comes from families, from churches, from communities, from healthcare settings, It's crazy. I had someone ask me a very funny question once, 30% of South Africans have, HIV. So that means everybody has HIV. Why is there stigma there, right? Everybody has an uncle, aunt, you know what I mean? Things like that. Why are you stigmatizing it, right? It's really important. And the reason why I think is also important too is that beyond it being a barrier to accessing and persisting with engagement healthcare services, but it snowballs, women get rejected, right? They become poor. And then that also further limits their access to healthcare services, so that intermixing with food insecurity, housing insecurity, relationship insecurity, things like that are really important. So, and then add to that also at the policy level, we criminalize risk behaviors, right? So sometimes I tell people, it doesn't matter what you feel, and I've had to learn that working in the US, right? I have my religious background, I have my own biases, right? I'm a human being, and I was brought up in a certain way, right? We have our biases and we carry them, okay? And I think as healthcare providers, as public health officials, check your biases at the door, close the door, and just ask yourself one question. What can I do to make this person's life better, okay? That's what we need to do, and that's the mindset we need to have. So we can talk all these beautiful things about new interventions, but nobody will use them if people feel that, coming to seek a service, stigmatizes them. So maybe we need to do away with HIV programs, seriously. Because we know who walks into an HIV program, right? And things, we label them HIV programs. We call them key populations, right? Right? So there's some things like that we do that are stigmatizing in and of themselves, but we don't think about it. So again, just a reminder, and I just have to say this, that I think that eliminating stigma is really important. So let me end with Nelson Mandela. It always seems impossible until it is done. So I've talked about cure. Maybe I made you depressed, or maybe I made you hopeful, or maybe I was just real with you. But I don't know if you're coming across with oh my God, there's so much to do. Oh my God, this is so hard. We're so backward. This needs too much resources. But the fact is that it's impossible, but someday I think we'll get some good news about a cure, about a vaccine that works, about treatments that are better for people living in a condition, maybe a way to eradicate these, to make life better. And I think all of us that went into medicine, or all of us who are healthcare providers, all of us who run programs, should be our dream and our desire for everyone. Thank you.
The panelists should probably step to the stage. But in the meantime, we have questions for the presenter on coronavirus. I haven't had from anyone who wants to ask a question, apart from Dr. Menela Sinheshman, who has a question for Dr. Musabeyezu and Dr. Jose Nyamusore. Anyone else with a question on coronavirus? So let's ask those two questions, one for Jose, another for Musabeyezu, and then the panelists on HIV, please, you can already go to the stage. Dr. Menelas.
I think you should plan also for fear. Fear is unintentional. Fear is contagious. Fear is uncontrollable. And you have seen that when we joined your team to respond to Ebola, we still had the same fear as we showed today for the same. So How are you planning to address that for this COVID-19? Are you planning for maybe mental health kind of accompaniment so that we don't let you down? I think you have to address that. Number two, the second question goes for Dr. Musaweyezu, Emmanuel. It's very straightforward. Considering what you have said, the risk and the air traffic that we get with the improved international travel, should we close down our borders to travelers from countries with active COVID-19 human-to-human transmission? And that is, as per CDC report, it's China, Iran, Italy, Japan, and South Korea. Thank you very much.
We do strategize to fight fear. That's why we have what we call the risk communication, community awareness and engagement. What does it mean? It means that number one, whose report do you believe? What are you fearing, by the way? Do you even know it? So which means, number one, we as intellectual, nano muntu wiga byinshi kuturuta. Nitwe dutinda cyane ku ishuri. Tusome. Let us read and read and read. Again, number two, the fear never stopped anything that was supposed to happen to not happen. Isn't it? So let us again prepare ourselves. Let us use the basics, infection prevention control. And then we'll be safe. What again? Let us get prepared. And we'll face anything. So let us be the champions, by the way, of to desenolize people. Don't spread rumors. I think we discussed with you sometimes back. Someone get a message on WhatsApp without even opening it. Share. What's the problem of sharing? What are you sharing? Open, read. Then the problem we have, as I said, I give this man all the tools that I've sending to all medical doctors. I think we put. How many did open them? I'm telling you, until tomorrow, there are among us someone who will not even open and read. So let us read. The rumor will be there. The media now is complicated. We no longer have these investigator journalists who dig things before saying. Now it is be the first to say. And it's a challenge. We'll deal with it. But let us. Nk'urugero, mukanya nguye hano mukanya. Mwese au kuntabara muzamfotora. That is it. If I can fall down now, instead of coming and look at me, you will take pictures. Because you want to publish and be the first one to publish. Isn't it? But what I'm saying, how many take the picture and say, Dr. Jose now, he's real al-kuduhi turachani. No one take that picture. Yes. Which means let us be the champion of circulating the science we know. Thank you very much.
What is the risk? What do I gain by closing, not flying to this country and preventing everyone coming from this country, versus what do I gain? And you have to remember, the China issue is broader than just the disease. China is the factory for the world. If you go to Kigali now, in the shops, they will tell you, we cannot go anymore to China. The price of this and that has gone up. Some of the things we cannot find anymore, including toilet paper, because it apparently was also coming from China. But the point I want to make is this. There is a certain number of cases in a country that you reach, and at that point you say the risk is high enough to say we should close the border. And there is the World Health Organization and the CDC guideline to categorize country in terms of risk, and that way we should look at the data to make a decision based on not what we fear, but rather based on the facts and from people who made decision from risk assessment.
I thought there were a number of take-home messages as far as the coronavirus is concerned.
Let's just make it very brief.
Yes,
not many of them.
Very brief.
Thank you.
Now, what I expected is, I mean, for instance, how vulnerable is it? I mean, Yeah, I mean, if you're washing surfaces, do you just use water? Are there any specific, antiseptics that one could use? And I think these are the issues actually probably that should have been raised. Now, maybe the other take-home message is, I mean, if it comes, should we put on masks? But I mean, as far as the science that we know today, the masks are advisable only for those people who are infected, so that they don't spread it. The other message probably one would take home is, it is actually not airborne. It is a droplet infection. It drops on the surfaces. You touch them, and then you can, the transmission when you get direct, introduction in the airway, and therefore when you go to the community, these are the issues actually when we get out of here, to alleviate fears of the community. Don't rush to buy masks when you get a case here. But only we can advise our patients to put on masks so that they don't spread it, those who are infected already. I thought these are some of the home messages that...
Without the chairman permission, I can quickly address this, and Nyamosore will also be happy to address this. I went to the fundamental of science because I was talking to an audience of doctors. When you go to the CDC, World Health Organization, and even RBC website, you find answers to these questions. What I went on to address were very deep fundamental science things, but these things you can find on CDC, World Health Organization, and even RBC website. There's some of these questions you're asking are there. I want to add something, I guess.
Dr. Grace, I think I will not go in deep to provide update on RCP. But the only update I would like to let you know is that you remember in the elections, Dr. Marcelin was elected as the secretary, but after some time he resigned because of his own reasons. So he was replaced by Dr. Grace. So that's why you have seen her sending message from the secretary side. So other updates, allow me, we will share with you in the next symposium, NCD symposium, we will have also General Assembly. Otherwise, we will stay for a long time here. So allow me then to thank all of you who have attended and who stayed till now. It has been a long and heavy day, but it was for right reason. I think we have had discussions which were helpful for our daily practice. So allow me to thank the RBC team, Dr. José, Dr. Placidi, she's not here. Yeah, Sister Maribori, thank you very much. It is not easy to get stakeholders for many hours in a room. I know you are very busy with emerging pandemics, you said? Yeah. So, but thank you. You have given this symposium priority. And even the DG of RBC was committing to be here, but he had other commitments which were very important than being here. So thank you very much, and tell the DG that we are really thankful. So we thank also pharmaceutical companies which supported us, Exfar, Inotech, Matfar, Breakcraft Pharma. They have been with us. You have seen them outside. But also Louis-Marie, he didn't want to be mentioned here, but he has been with us during the organization until today. So he has been supporting us. He's not there. Yeah, Louis-Marie. I'm sorry, I didn't respect your request, but we have to be thankful. So I want also to thank the organizing team. If they can come just in front, together with the board of RCP. Would you come, please? These people have been working very hard, night, day, and it was just volunteering. So thank you very much. And we have really new blood. We have to support them. And I take this opportunity to thank the seniors who are here, Dr. Joseph, Dr. Msemakweli. We have to inspire young people. Professional networking has been proven to be very effective in upgrading knowledge and skills. So we have to keep that professional networking. It is very important. I can see we are with the undergraduate students. Please keep supporting RCP so that it can grow. And at some point, we have to have our fellowship organized so that we cannot just stay at the internal medicine level, but be sub-specialized. So I would not forget, you are not the last, least but not last, last but not least, sorry. So Professor Andre Van is flying back home, but he came specially for this symposium. So we had time to thank him, and he's committed to be with us always, and he's committed also to be part of the advisory board. So he will be always with us. So Professor Onyema, you have seen, he came today especially for this symposium. Professor Onyema has been involved in shaping internal medicine curriculum and education in Rwanda. So Professor Onyema, you are Rwandan. So thank you very much. Thank you very much, Professor Onyema. You have a small recognition. It is small, but comes from the bottom of our hearts. Just a small thing. So we should get this or other recognition for other people, but we are still building our college. The next time we get for RBC for everyone. So this comes to say that we are happy to be with you at the cocktail. Please don't miss. It is good to interact, not just talking medicine and science, but also networking, social, and so on. So this comes to say thank you very much, and we look forward to meeting you again in August for NCD Symposium. Thank you very much. So we officially close.